I hope all of you enjoyed your Pongal. Back to work after 2 days of relaxation. Uh, how many of you read the title of the class today? Isha,
I have read, sir. Yes,
what
sir.
is
We have
RFD?
read, sir. Sir,
Given
pardon, sir.
RFD short case inhibitors. So ibuprofen or indomethacin can be given. First dose is 10 milligram per kg, and for ibuprofen it is 0 for ibuprofen and 0.2 milligram per kg for indomethacin. That is the dose. Sometimes they may ask you this also. And if PDA does not close or significantly reduced in size, further doses may be increased at the 24-hour intervals up to a maximum of 3 doses. Second and third doses are 5 milligram per kg, while for indomethacin it will depend on the age of the infant, and it may vary from 0.1 to 0.25 milligram per kg. What are the other options for treatment? You said about ligation. Anything less invasive than that?
Balloon.
Nowadays, everything we do transarterially. The majority of the things are passed through that, so we can transcatheter PDA device closure. That is called transcatheter PDA device closure in cardiac catheterization lab, or surgical ligation of PDA are the treatment options for PDA closure. Okay. What are the anesthetic challenges in these procedures?
Due to pulmonary congestion, there will be LRI.
Okay.
Avoid hypoxia.
One second. This is the question you are going to, this anesthetic challenges in the procedures or in this case. This question is going to come in every case scenario I am giving. So this part is very, very important. In the examination, if you analyze the case and then present it as the anesthetic challenges 1, 2, 3, then it will be easy for the examiners to identify your knowledge and appreciate it. And it is easier for you to remember how to go about and describe the further management also. So what is the first and foremost anesthetic challenge you have to say in this case? It's a
Pediatric.
Even in the pediatric, it is an infant. 4 months is a very, very small baby. Okay. So it is an infant. So challenges of newborn, or sometimes there may be preterm infants also. Okay. So that is the first and foremost challenge. Then what is the next thing you have to think of? If it is supposing PDA device closure, can it be done under local like you do in an adult?
Difficult airway and difficult venous access.
See, those are all
The baby
challenges.
won't stay still. Yes.
No, supposing they ask you to come and attend to a child who is going to undergo a device closure in the cath lab. Can this procedure be done under local anesthesia, like you do the transcatheter procedures or transarterial procedures in an adult? For example, even TAVI, if you want to do transarterial aortic valve replacement, you can just do it under sedation for an adult. But and a 4-month-old baby be quiet when you do the device closure in the cath lab?
No, sir.
No, sir.
No, sir.
Supposing they ask you to give anesthesia for a child in the cath lab, what are the challenges?
Non-operative.
It is a NORA procedure. Excellent. That is the first and foremost thing you have to remember. Okay, and that too, managing a 4-month-old baby in a cath lab is a very huge challenge. So NORA procedure will be there. So NORA, if transcatheter device closure is performed in the cath lab, and challenges of anesthesia for thoracotomy or VATS for surgical ligation. Okay, and so these are all the challenges that you have to think of. Now we are going to the second case scenario. So beyond that, I am not discussing. So all the discussions are going to be only just like this, up to some important questions that are commonly asked in the examination. So it will not be a detailed discussion as we do in a regular class. So the next, what is the condition shown here?
Bilateral
Congenital.
Bilateral congenital talipes. Okay, always the exam, don't use abbreviations. Try to say the full expanded version as much as possible. So this is a case of congenital bilateral talipes equinovarus. How is this condition treated?
So initially
Mainly
conservative
depending on the age.
management.
One at a time. Take turns. All of you can answer. If the same person is going to answer, the others don't get the feel of attending an exam. Okay, so even give chance to everyone so that everyone can answer.
So depending upon the age, initially we can try conservatively using the cast and the shoes.
Very good.
We can advise the mother to
Yeah, you're right. Conservative management with cast and correction. Okay, course correction is the thing to correct. Then that is the cases, mild cases, which can be as the child grows, it may get automatically corrected with these boots and casts. What if it is not getting corrected? That is the second half, you know. So if they ask you what is the condition, how is the condition treated, you have to say the both conservative and operative treatment. You cannot just stop with conservative alone. What is the operative treatment you have to do?
tenotomy and
Tendon transfer.
tendon transfer.
Tendon transfer is not the word. It is,
Medial soft tissue release.
tendon lengthening can be done. TA lengthening. It is not just tenotomy. It is a TA lengthening procedure can be done, or you can do soft tissue release. Okay, these are the two surgical procedures that are done. So conservative serial correction with POP application in mild deformity, operative correction by soft tissue release and bony alignment or tendon lengthening in severe deformity or failed conservative treatment. Okay, that is the full answer for this treatment of this condition. What are the challenges in anesthesia? How it is managed?
Pediatric
Supposing a
patient.
9-month-old baby is posted for open repair of congenital Talipes equinovarus with soft tissue release and K-wire fixation of the talonavicular joint. That is the plan. What are the challenges in the anesthesia?
Number 1, pediatric patients, sir.
Fantastic.
Number
That is the
2.
answer you are going to say every time. Okay. The challenges of pediatric anesthesia is the first and foremost challenge inherent to pediatric anesthesia. Then
It can be associated with any neuromuscular disorders.
you have to rule out. Okay. Rule out any congenital defects in other systems. All the time, whenever you get any congenital abnormality, please add this sentence also to your answer. I will rule out other congenital abnormalities may be present in the CVS or in the musculoskeletal system or in other parts, other systems may be affected. So I have to rule out other congenital anomalies. Anesthesia, how is it managed? What is the technique of anesthesia?
Along with caudal analgesia.
So does it require general anesthesia all the time, or can you just manage with caudal and sedation?
Yes, sir. Caudal and sedation, also mask holding.
Yes, mask holding or a mask can be fitted to the face, and you can ask, make the baby inhale the water and breathe spontaneously. If the block is quite effective, that can also be done. Okay.
Yes,
so anesthesia
sir.
can be caudal block plus IV sedation or inhalation agents, or GA if you are not sure, or if the caudal is not, if you are not confident about caudal or it is not taken up, then GA with either ET tube or LMA. And if you are planning for a GA in a very restless child, especially older children with anxiety of separation from the parents, they may not be remaining quiet with sedation alone. So in that case, you can plan for a GA with caudal and a nerve block. Which nerve block can be utilized for this?
Sciatic, sir.
Popliteal sciatic.
Sciatic. Anything lower down, popliteal nerve block can be given. Okay. So you can block it at lower down instead of the whole sciatic nerve of the origin. You can go for a popliteal nerve block. What is this condition shown here?
Left leg varicose veins.
It is a varicose veins in an adult patient or a
Adult patient.
Adult patient. Is it more
Adult
on one
patient,
leg and
left
less
side.
on another leg?
Left
or
side.
It is more on left side. So whole description should be given. Okay, it is a case of varicose veins more on the left side than on the right side in an adult patient. Okay, so bilateral varicose veins more severe on left side. What is the treatment option for this?
Stripping,
Sclerotherapy, surgical
sclerotherapy, stripping.
radio frequency ablation,
Okay.
sclerotherapy.
Okay, good. Mild cases treated conservatively with leg elevation, compression stocking, sclerotherapy, or endovascular laser therapy, which is a newer thing which has come out. And surgical treatment is vein stripping, external valvuloplasty in severe cases. Okay. How do you manage this case anesthetically? What are the
Can you
anesthetic
IV
options?
sedation?
IV sedation for conservative treatment, but if it is varicose vein stripping, major procedure,
Central neuraxial blockade, sir.
central neuraxial blockade is preferred. What other things you have to take care before you think of
But
central
if
neuraxial?
they want ambulation immediately post surgery, then we can go for short GA with LMA.
Okay. To rule out other peripheral vascular diseases, you can think of central neuraxial blockade, nerve block, or GA. These are the options. Okay. So we will not be discussing anything in detail. How you do about how you what pre-medication, all that will not be discussed. So you have to know the basics how to answer. So the options are spinal or epidural, a nerve block, or GA are the options for this case. A 1-year-old boy with a tight phimosis. Yeah, all of you have seen the picture. What are the challenges in anesthesia in this case? Procedures for circumcision.
Neonatal concerns with regards to neonatal anesthesia.
1-year-old boy. Here the age is given. It is
Infant.
It is an infant or slightly older child learner newborn. So it is a pediatric anesthesia. Okay. If it is less than very, very small baby, like 3 months, 2 months, you can say infant anesthesia. Here it is almost the child may be walking about, now the toddler. So it is a pediatric anesthesia, including
Separation.
danger and separation anxiety. This is the most important thing that will be happening in this age group. Okay, the child will not be very comfortable to be away from the mother. Okay. Any other challenges? Supposing you give inadequate anesthesia for a circumcision, what can happen in the baby? You give a caudal block, you have not tested properly whether the caudal is working or not, and you allow the surgeon to paint and drape and start the surgery. And he puts the clamp to catch hold of the preputial skin. What can happen at the time if the block is not effective?
Spasm.
Sinus
Bradycardia.
Straight away bradycardia. After
Hypoxia.
caudal block, you are not giving GA. Patient is breathing spontaneously.
Bronchospasm.
Laryngospasm. That is a very, very important, dangerous complication that can happen in circumcision surgery. If you read, if you happen to know, I've heard about the book called Synopsis of Lee. Have you ever heard of the book Synopsis of Anesthesia by Alfred Lee?
Yes, sir.
Have you ever seen that book? That used to be the Bible for us during our student days. And in that the chapter on anesthesia for circumcision, there is a single sentence which is still till today I cannot forget. In that he says, anesthesia in those days it used to be induction with an IV agent for older children coming for circumcision. The technique used to be IV induction with thiopentone. Those days we did not have propofol, and we used to give analgesic with either pethidine or morphine IV, followed by holding the mask with gas oxygen and ether or trilene. These are the agents that we used to keep the child quiet by inhalation technique with spontaneous breathing. And occasionally we used to give the penile block also before we allow the surgeon to operate. And then by chance, if the analgesia is not adequate, especially in children who are very anxious and crying because of separation anxiety, The first painful stimulus used to create a very severe laryngospasm. The child will, that noise will come and child will choke and immediately it will go for desaturation, bradycardia, sometimes even arrest can happen. So we always used to say that anesthesia is very challenging for circumcision in those days. And the one sentence which we used to have in that book is, it is anesthesia for circumcision can be clumsy even in experienced hand at times. That is the sentence which I still remember in my book. So anesthesia for circumcision can be clumsy even in experienced hands. So that much of challenge used to be there. Okay? So possibility of recent LRI or innocuous URI on the day of surgery. This is the common scenario the examiners will ask you. Supposing you, this is a daycare procedure, isn't it? Most of them are asked to come on the day of surgery. They are operated and sent home on the same day. Supposing the child has a running nose on the day, and the mother says, till yesterday night, the child was perfectly all right. Only today morning it is having a running nose. How to distinguish between a infective LRI and innocuous URI?
Sir, by history and by the character of secretion by auscultating.
More than that, what is the first and foremost history you will ask? Supposing it is a bacterial infection and the child is starting in a LRI infection, what is the first thing the child will have before they show any
fever history?
The child be active like normal?
No.
It may have a mild low-grade fever, okay, and it will not take the feeds properly. These are the three important starting things before any infection or any LRI in a child. Child will become little lethargic, dull. Second, it will not take the feeds properly. Third, it may have a low-grade fever also. Whereas in an innocuous LRI, because of crying also, you can get watery discharge from the nose. That child will be active and very violent. Okay? So you can easily distinguish between an innocuous LRI and an infective, URI and an infective LRI by these clinical symptoms and history. Okay? And if it is a significant indication of an LRI or a starting of an LRI, it is better to postpone. But if it is an innocuous URI with just a watery secretion from the nostrils, which happened after crying, you can safely take up the child after making sure that there are no lung signs by auscultation. Okay, so this is the very common question they will ask you. And the third thing is inadequate anesthesia can produce dangerous laryngospasm. So that is another challenge, as I told you, in this particular surgery. So what are the types of anesthesia provided for this surgery?
General anesthesia with caudal block, sir.
Dorsal penile block.
So you can classify into regional and general and combined regional and general. So older children with ketamine sedation, you can give a caudal block and allow the child to remain unconscious and cooperative with spontaneous breathing. But if a very small child who is likely to wake up and cry or become restless after the effect of ketamine wears off, it is better to go for general anesthesia, either by mask ventilation or by intubation and regular anesthesia with inhalation agents. Okay, so there are choices of EA with inhalation or intravenous injection, maintenance with inhalation agents or all doses of IV agents, spontaneous versus controlled ventilation. So controlled ventilation is usually for the marathon surgeon who may do a circumcision for 1.5 hours. Okay, such people you have to better control ventilation. So you must know the ability of your surgeon also as an anesthesiologist. And the airway control maybe with the face mask, LMA or ETP. Okay. RA, caudal block, penile block, with or without sedation. So older children, we can do it with penile and caudal block alone, and with quite a good rapport and comfort, we can keep them cooperative. This is a case of bilateral cataract for phaco and IOL in a child. Okay. So what are the challenges in this case?
So pediatric age group.
Always, whenever you have a pediatric child or case, you must first say it is a pediatric age group. So challenges of pediatric anesthesia, including stranger anxiety, depending upon the age. Okay. Then what is the next thing?
Oculocardiac reflex.
The two important reflexes which are peculiar to the surgery in the eye. One is oculocardiac, another is, what is the other one? Problem.
Trigeminocardia.
Geminocardiac is also the oculocardiac. Oculoemetic. Okay, so oculocardiac reflex due to various reasons, and in this case we have to be aware of raised intraocular pressure, because if there is a phaco surgery, they will have to go through the cornea into the anterior chamber and then pulverize the lens material and suck it. So it's an intraocular surgery. So we have to avoid any raising IOP. That is a very, very important intraocular conditions for anesthesia in this case. So can you use ketamine in this case for induction, being a small child?
No, sir. It will cause increase in intraocular pressure.
It will cause an increase in IOP. So ketamine is not an agent to be used in this case. Okay. And prevention of post-op pain to avoid crying of the child, which again also can raise the IOP. So adequate post-op pain relief is important. And lastly, prevention of post-op nausea and vomiting, which again can raise the IOP. Okay. So there are so many challenges are there. How do you manage the anesthesia for this case? Supposing it is a 1.5-year-old baby, what I have shown here. It is posted for bilateral phacoemulsification and IOL placement. How will you anesthetize the child?
GA with block for post-op.
What block? Caudal block.
No, sir.
Be specific about your block. Exam, don't take chances at all. There are quixotic examiners like me, maybe asking you caudal block and Kepang, just to make fun of you. Okay. So very, very specific answers should be given. GA with a retrobulbar or a peribulbar block. Which is preferable, peribulbar or retrobulbar?
Peribulbar block can be given.
Why peribulbar is more safer than retrobulbar? What is the difference between retrobulbar and peribulbar? These questions can come as an offshoot.
Peribulbar, the injection is outside the muscular cone.
Muscle cone. That is the word that we have to use. What is the cone formed by? Muscle cone. How is it formed?
It's formed by rectus muscles, medial
extraocular muscles. One word answer for that. The main 4 extraocular muscles form what is called the muscular cone. So in the retrobulbar, the drug is injected into the cone. Okay, so it is more dangerous because it is in close proximity with the optic nerve and major vessels, but the volume required will be very much less. Whereas in peribulbar, the drug is deposited outside the muscle cone, and the volume required is slightly higher than that. Okay. And some people who practice ophthalmic anesthesia may ask you, will this block increase the IOP or not? Intraocular pressure, will it be increased?
No, sir, it does not increase.
No, sir.
No. Some surgeons may object to it because they don't want to face that. But you can say you can reduce the pressure by one technique. How?
By massaging.
By massaging. Or by, how can you make the drug spread evenly to all the planes? what drug you can add to the local anesthetic agent?
Hyaluronidase.
Hyaluronidase
Hyaluronidase.
will help in dispersing the local anesthetic into all the planes of the muscular area. So it will not be deposited in one particular location, which is the main reason for sometimes the IOP getting increased by from the external compression of this volume of local anesthetic. So if hyaluronidase is added, this problem can be avoided. Okay, so that these are all the output questions you should be prepared to answer. So GA with or without periorbital peribulbar block, smooth induction and emergence is required because you should not cause any raise in IOP. And maintenance can be done with either spontaneous or controlled ventilation. Airway can be managed with a fluxometallic LMA, which is usually only by experienced anesthetists will do that, or you have to go for VT intubation with oral ray or fluxometallic tube, because a normal vortex tube will be jetting out and that may get kinked by the drapes and the coverings. So it is better to use a fluxometallic or a oral RAE tube which will flush with the chin, so that there will not be any obstruction. So these are the points that you have to remember for cataract. Here again, the diagnosis given is a cystic hygroma for excision. Challenges in providing anesthesia for this case.
Pediatric age, difficult airway.
Very good.
Uh,
Such a huge swelling.
Difficult positioning of
difficult airway in all the ways, sir. Bag mask ventilation, intubation, front of neck axis.
Yeah, that's agreed. Anything
Shared
else
airway,
because
sir.
of shared airway? This is usually outside, you know. You can make an incision, it's like a thyroid excision, cystic hygroma. You can make an incision on the skin and remove the.
Since it is a big swelling, there will be fluid shift.
What are you seeing here? A lot of
blood vessels bleeding and
bleeding. So tortuous vessels, you know, there can be a lot of bleeding, and such a small child, tiny child with so much of bleeding, what can happen? Hypovolemia cannot be tolerated. Okay, so challenges of pediatric anesthesia, specifically if it is a very small baby like this, infant anesthesia, anticipated difficult airway, importance of decision making to secure airway, either awake or asleep. So how do you decide whether you can go ahead with a conventional induction and paralysis and intubation, or intubation with FOB and the topical? How to decide that in these cases, in a baby like this? Is the mouth opening looking good here in this case, this picture?
yes, sir. Yes, sir.
Can you put a scope and see how far you can see?
Yes, sir.
So you can do what is called a trial laryngoscopy. Okay.
Okay,
So you
sir.
can do a trial scopy by applying a little bit of xylocaine jelly to the tip of the laryngoscope. You can proceed. The child will not resist too much because a small baby, like an adult, it will not clench the mouth or try to bite or anything. So you do a trial scopy, and if you are able to see the epiglottis without any relaxant in an awake child, you can definitely intubate the child. So what you can do is take the child deep enough by inhalation agent, and then do the scopy and intubate the child while the patient is breathing spontaneously. Or you can try a FOB and intubate in a deeper plane of anesthesia without any difficulty. Okay, so that is how the decision making is done. And the intraoperative blood loss and need to maintain volume because of this particular picture showing a lot of vessels on the surface, and possibility of post of airway edema. Once the gland has been removed, just like a thyroid swelling, this will be compressing the trachea for a long time, and that may collapse. So airway obstruction to be anticipated. And supposing you anticipate airway obstruction, what will you do at the end of the surgery? Will you extubate straight away, or will you do some other maneuver?
Nasopharyngeal airway, sir.
Tracheostomy.
Tracheostomy is one option.
We can tie the tongue to the floor of the.
No, once this gland is removed, it is mainly the obstruction will be at the tracheal level. It will not be at the upper airway like tongue or pharynx. So it
Maybe
will be at the glottic or the
electroventilation.
below the glottic airway. Can you put a exchanger?
Exchange
Yeah,
airway
you
catheter.
You can put a tube exchanger and then extubate so that you can re-intubate at any time. We have such very tiny tube exchangers available with our facilities to oxygenate the babies also.
Yes.
And what are the management of anesthesia? How do you do that? Supposing this case is posted and you are the anesthetist. These are the challenges you have already thought of. So how
Yes.
do you manage the anesthesia for this child?
Sir, as you said, we can do a check laryngoscopy and intubate, or we can intubate through FOB.
So securing the
Once
airway is the most important challenge in this case, right? So once
Yes,
you
sir.
secure the airway, then the other things are all routine anesthesia. So the management GA with a secured airway, that is the answer that you have to give.
Yes.
And because it's a small baby, it cannot be done under any local or any regional block. So GA with secured airway is the answer. So through airway evaluation, decision regarding securing the airway, either regular induction followed by direct-scopy and intubation, or fiber optic under inhalation anesthesia, preserving spontaneous respiration. This is the first and foremost challenge. Then decision to perform elective tracheostomy. That has to be done with consultation with the surgeon, and reserve adequate compatible blood administered after warming to prevent hypothermia if needed because of the vessels that you see.
Sir, this case is a pediatric
So
case.
this is a, pardon?
Sir, this is a pediatric case. So how can it be a long-standing ulcer so that the tracheal collapse?
I'm not able to hear. Who is speaking?
Sir, Dr. Geeta, sir. Hello, sir.
Your voice is not clear, ma. Mic is having some problem.
Can you hear me now, please?
Yeah, it is better now.
Hello.
What is your question? Okay, if you are not using connection, others are able to hear me?
Yes, sir.
Yes,
Sir,
sir.
you can type in the chat box also, sir. Any questions, you can type in the chat box.
Yeah, tell them that. So thoracolumbar scoliosis for correction. So this is an adolescent patient. All of you would have had a detailed class on scoliosis surgery. So again, the first question is challenges in this case.
Look for other
Sir,
congenital defects.
Look for other, it can be acquired also. Why congenital? No, scoliosis can be acquired and congenital. So how do you decide it is a congenital and why look for congenital associated with other problems?
so neuro
Respiratory function.
perioperative.
See, the defect is so bad that this side chest looks very narrow and this side looks big. So the lung development or the lung expansion on the affected side is the first and foremost concern. Okay. So thorough preoperative evaluation of disability, respiratory, cardiovascular system, and airway. These are the four things that you have to keep in mind. Because disability is mainly for the patient pain or walking difficulty and all that. But from anesthesia point of view, we have to evaluate the respiratory system. So what respiratory problem these patients can have?
Restrictive lung
Disorder.
Restrictive lung disease with inadequate expansion that can lead to what sort of cardiovascular problem?
Pulmonary artery hypertension.
Pulmonary artery hypertension and right heart failure. Fantastic. That is another important thing you have to rule out. So what are all the features of right heart failure?
elevated jugular venous pulse, pressure,
Congestive hepatomegaly.
So that will be all in very advanced cases. Early cases, it will be dyspnea, shortness of breath, or syncope. These are the two things that have to be eliminated. Okay. If they have gross JVP, Raisa, hepatosplenomegaly, all that, that is very, very late stage. So early stages of pulmonary hypertension clinically are detected by patient having shortness of breath even for minimal exertion and history of syncope. Very, very important. Okay? And airway sometimes can also be affected because of the wrong posture that they have. They tend to have a deviation of the head and neck to also to one side. So that may cause airway difficulty also. The second is discussion with surgeon regarding intraoperative nerve stimulation, whether they are going to do it or not. Why this is important? If the surgeon says, yes, I am going to do the intraoperative neuromonitoring to stimulate the nerve and see whether I am damaging any nerve or not. So
You have to modify the
Muscle relaxant should be
agents,
used.
you have to avoid muscle relaxant and
volatile agents.
volatile agents to get the correct response for the neuromonitoring. So how do you maintain anesthesia in that case? If you are not going to paralyze,
you maintain
Intravenous anesthesia.
total intravenous anesthesia. Okay, that is the answer that you have to give. And problems in positioning to be thought of and planned because the patient is going to be this curvature. One side will be hinging out, and the other side will be depressed. So even lying down may be problematic. And normally for this surgery, how do you induce anesthesia? On the operating table or on the stretcher trolley?
on the trolley will induce.
You induce in the trolley and then transfer the patient to the operating table. So what are the precautions you have to take if you are going to induce anesthesia in the trolley and intubate the patient?
So we have to lock the trolley.
You have to lock the trolley, otherwise it may move. So you have to see whether the trolley wheels have got a lock or not. And you must have a good assistance to help you to with the laryngoscopy and intubation. So, and next thing is prevention of blood loss. So what method has to be used? So that also has to be consulted with the surgeon. What are the techniques of preventing intraoperative blood loss in spine surgery, scoliosis surgery?
Hypotensive anesthesia.
Hypotensive anesthesia.
Positioning with bolsters to prevent increase in the intra-abdominal pressures.
Okay, that is positioning.
Use of drugs like tranexamic acid. Bolsters
So
are
every
infused.
step you have to say right from the start how you prepare. So first is proper positioning to prevent any compression in the abdomen to increase the intra-abdominal pressure, and that will reflect on the increased venous pressure, that will reflect on the venous pressure inside the epidural veins that may cause the bleeding. So proper positioning is very important. Preoperative tranexamic acid given well in advance before incision is also very, very important. The third thing is correct plane of anesthesia, because inadequate plane and perception of pain will cause tachycardia and hypertension that will aggravate the bleeding. So correct plane of anesthesia and depth of anesthesia is very important, especially if you are going to depend on only TIVA. You may have to use what monitor has to be used if it is going to be a TIVA anesthesia.
Bispectral
Depth of anesthesia monitoring.
Depth of anesthesia monitoring using bispectral index is also to be included if it is going to be a TIVA. And you can infiltrate the surgical area. You can allow the surgeon to infiltrate with adrenaline saline before under the skin and subcutaneous tissues. Or you can go for hypotensive anesthesia. But what is the risk of hypotensive anesthesia when you are planning for a neuromonitoring?
Spinal ischemias.
Spinal ischemia can happen. Okay, and also the neuro responses may not be adequate, so that are also to be decided. So these are all the points that may ask you. And prevention of hypothermia because of the extensive exposure and long duration of surgery. So what are all the things that you have to take care to prevent hypothermia? Routine questions.
Sir, by covering the patient adequately.
Always start from the ambient temperature.
Yes.
That is the main culprit. No, if you keep the temperature of the OT very, very cold, like 16 and 14, Some surgeons, who sweat a lot, they want the OT temperature to be between 14 and 16. But it is ideal to have between 18 to 22 if it is an adult. So keep the OT temperature slightly higher. Then plan for all warming devices for IV fluids,
air warmer,
air warmer, air hugger. All the covered parts should be well, and temperature monitoring also will help you to maintain the temperature to the normal level. And prevention of post-op pain. What are the techniques to be planned in advance? What are the methods of providing post-op pain relief after spine surgery, which is commonly used nowadays? Many
patient controlled
Patient-controlled
anesthesia.
anesthesia.
patient-controlled regional techniques.
IV OP.
Block.
Regional erector spinal block. Yes, that is a very, very common thing that is being used nowadays for all spine surgeries. So you can give an erector spinal block under ultrasound guidance before the start of the surgery. And sometimes you can even put a catheter and continue that. And in some centers, they put a epidural catheter. The surgeon himself, before closure of the wound, puts an epidural catheter, and through that you can use the epidural infusions. But most surgeons are not in favor of that because of the possibility of infection. But that is also one of the accepted techniques. So these are all the challenges that you have to face. Now coming to management of anesthesia. How do you manage?
General anesthesia with flexometallic.
General anesthesia, intubation with flexometallic tube. So first and foremost, step is secure a whiteboard, peripheral access. Use always a blood administration IV set with a filter because many of them may require a blood transfusion, especially multiple level scoliosis correction. And anesthesia by IV induction and intubation with a tough flexometallic tube done in a stretcher trolley. So, as I told earlier, you have to lock the wheels and keep this trolley immobile and make sure that you are having a good access at the head end, because some of the trolleys may have a bar coming, will keep projecting outside. So you will be a little away from that. So make sure that you bring the patient as close to you as possible before you start the induction. And apply only pulse oximeter probe and beat it up during this stage. ECGs leads can be placed after turning the patient home onto the operating table. And take care of IV access and ET tube while turning the patient, supporting the head and neck properly. And while positioning, what is the important thing you have to take care of? You position the patient on the operating table with the support. Where should the supports be placed?
We should avoid injury to the eye.
I'm asking where the supports should be placed. I'm asking the patient to be placed. Which part of the body the support should be?
We should be in the head end with holding the tube on one side and on the occiput and the cervical vertebra.
I'm not asking about how you secure the tube. I'm
One chest support and one
support for the body. How are you going to do that? Patient
one under the chest, sir.
Just above the diaphragm. That is a very important thing. Okay, it should be placed above the diaphragm on the chest and preferably up to the clavicle. And below the diaphragm, it should be mainly on the pelvis. It should not encroach onto the navel area. So you must keep the umbilical area completely free. That is the correct method of positioning. Okay. So when you, after positioning, if you insert your hand, you should be able to insert your hand between the table and the patient's abdominal wall. Okay, that is the correct way of placing. But patients who have a very huge paunch, a big abdomen, then there are supports which have a central hole to allow the abdominal wall to hang through that without being restricted. Okay, so that is the thing that you have to remember. And then you have to take care of the pressure points as well as the eye. But what about the cervical spine and the upper thoracic spine? How is the position maintained in that level? It should be little down and up, or it should be in alignment.
It should be in alignment, sir.
It should be alignment, yes. So it should be in straight line. Many times, most of the junior people or the junior surgeons, they don't take care of that. They allow the cervical spine to be flexed from the upper body support. That will cause severe post-op problem, and edema will be more. So you have to keep the cervical spine in alignment or in straight line with the upper thoracic spine. That is the correct way of positioning the head and neck. And place no neuromonitoring leads before painting and draping. Ensures free movement of diaphragm, specifically in patients with central obesity. Eyes to be well protected by adequate padding. Cervical and upper thoracic spines to be aligned in straight line to prevent neck getting flexed, and the tube also will be thin. And ET tube well secured to prevent loosening of plaster by oral secretions. And in these cases, definitely we have to give glycopyrrolate IV to reduce the oral secretions, because we are turning the patient into prone position. And the position and length of the tube after intubation with the confirmation of the air entry, you can write it on the plaster itself. What 20, whether it is 23 centimeters or 21 centimeters, you can mark it so that you can see whether there is tube is getting slipped out or going in. And do a head-to-toe survey for all pressure points and position of limbs to prevent hyperabduction or acute flexion. And intraoperative maintenance to be decided between conventional controlled ventilation with neuromuscular blocking drugs and inflation agents, or PIVA avoiding muscle paralysis and volatiles, based on whether you are going to do neuromuscular monitoring or not. Okay, that will decide the intraoperative maintenance technique. And prevent blood loss during surgery by adequate depth of anesthesia, induced hypertension, injection of dilute epinephrine and saline, with or without LA drug, tranexamic acid before surgery can be done. And another common question is, what are the techniques followed to conserve blood in these cases, major scoliosis surgery? Just showed it for a clue. Three important things that are described: conservation of blood in scoliosis surgery.
Acute normovolemic.
Normovolemic, normo-unique, it is not nothing unique, it is volemic, normovolemic hemodilution. That is to be done on the day of surgery. Before surgery, in the
Autologous pre-deposits. Autologous pre-deposit.
Autologous donation, yes, it is called autologous donation of the blood by the patient himself. What are the criteria to decide whether a patient can donate his own blood for surgery?
Surgery should be at least 1 week after the blood donation, and the patient should have hemoglobin of at least 11 grams per deciliter. 14 grams, not 11. 11 you cannot take. You have to have a hemoglobin of 14 grams. And you can do, if he has a hemoglobin of 14 grams, how many times you can deposit or donate? You can donate up to 3 times at weekly intervals by giving iron supplements and the other folic acids. Okay, so up to 3 times patient can donate if he has a HP of 14 grams and above. And that is not possible. The next option is acute normovolemic hemodilution done on the day of surgery, where before induction you drain about 350 ml of blood and then replace it with how much of crystalloid or colloid? Sir, 1.5 times the crystalloid or 1 times the colloid?
More than that. Crystalloid you have to give 3 times. 1:3 and equal volume of colloid. Okay. And the third option is the autologous pre-donation is one, Acute normovolemic hemodilution is 2. The third option is
Cell
cell
salvage.
salvage during surgery. Okay, you can collect the blood that is being using out in the operative field, and then wash it and reintroduce that. That's called cell salvage. So autologous blood donation during pre-op phase, acute normovolemic blood donation on the day of surgery, and intra-op cell salvage or other methods. This is a very, very common question they will ask you. So remember all the 3 methods. I'm showing some of the defects in the lip and palate. So you should be able to identify the type of defect, the surgical defect that is described. Because these short cases, they may give you a live patient. So you must be able to identify what type of cleft it is. What is the cleft that is shown here?
Bilateral.
Bilateral complete.
Bilateral complete. Is the nose is normal or abnormal?
Nose is normal.
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 The nostril sill is complete. There is no defect in that. No, what will you call it?
Incomplete.
Incomplete cleft. Only when the nostril is flayed away, the ala is not touching the midline, then it is called the complete. Okay. Here you can see a bridge of skin is still intact and the nose looks normal. Nose is not deviated. Okay. So that is the important difference that you should know. Now I am showing you another case. What is this condition?
Unilateral.
So here it is, you can see the difference between these 2 cases. Here the nose looks absolutely fine, and here this part of the nose is looking normal. Whereas here you can see there is a cleft going up into the base of this is the nostril sill. This portion is called the nostril sill. Okay. So when the cleft is extending into the nostril sill, it is complete. Okay, so this is a bilateral cleft lip, complete on left side and incomplete on the right side. Understand that? Now this is the third picture.
Bilateral
Bilateral complete.
Bilateral complete cleft lip. Okay, that is how. Are you able to now identify the difference?
Yes, sir.
Yes, sir.
Very good. So this is a very important, and you must see
Sir,
inside
second
the
case
mouth also.
complete on the right side, sir. So second case is complete on right, I think, not on left.
Oh, sorry, right. From here, yeah, right. Complete on left, right, and incomplete on right. Wrongly typed. Sorry, you are right. This is incomplete on the left and complete on the right. You are right. My typing mistake. I agree with that. And this is complete cleft on both sides. Okay, and this is the premaxillary area. This is called the premaxillary projection. What is the importance of this premaxillary projection?
It forms the philtrum.
In some cases, this may be protruding very badly outside. So when you try to do the scopy, you may fracture that. Okay? This may have a very small, fragile bony attachment to the nose. So that may get fractured. Okay? So that is, and it may also cause a very severe difficulty in intubation. And in the exam, if they keep you cases like this, don't just examine the lip alone and stop. Open the mouth and see whether there is a cleft inside also. Then you have to add the diagnosis to that. Bilateral cleft lip with the cleft of the palate. That also has to be seen. So always look into the mouth and see whether the hard palate and soft palate are intact or there is a cleft also there. But for discussion, just given these types for you to identify each of these, and what are the challenges in these cases? First routine answer.
Pediatric age
Pediatric
groups.
Pediatric age group. Challenges of infant anesthesia, because they are all done at a very young age. What is the age at which lip has to be repaired? What is the age at
Lip as soon as
3
possible,
months.
sir.
3
as soon
months.
as
3
possible,
months, sir.
at least by 3 months. Okay, if the child is of adequate weight and good hemoglobin and with no other problems, you can repair it even at 2 months. Earlier it was maximum 3 months, but as early as possible it should be repaired. But palate you can do it at before the 9th month of age or before the child starts to utter some syllables or speak.
Phonation.
That is phonation. Okay, it is not phonation actually, because the child crying also is phonation. But
Right.
before it starts to attempt to speak or say some syllables like pa, ma, tata, all those things. And challenges of anticipated difficult airway. Sometimes it may be quite difficult to visualize the larynx. That is the second challenge. Anything else?
Shared airway and more prone for bronchospasm.
Fantastic.
Shared
Not
body, yes.
bronchospasm, shared airway is a third challenge. Then
Airway edema and
airway edema and so possibility of post-op airway obstruction, specifically after palate repair. Very good. Then anything else? So these are the 4 things that you have to remember as challenges. Important to ask for what are the importance of pre-op history and evaluation.
Feeding history, sir.
Huh?
Feeding, how they feed the child.
Feeding
Respiratory
history.
infections.
First of all, always when congenital defects like this are given, start from the antenatal
history.
birth history and then go to the other practical problems. Okay, so first is history of consanguinity between parents and birth history, whether it is a term baby or a preterm baby, and whether it's a normal vaginal delivery or a C-section, and other congenital anomalies, whether they were found out immediately after birth in the newborn time itself, and then history of feeding difficulty, how it was managed, and any airway obstruction, especially in peri-Robin sequence cases, and how it was managed. History of recurrent chest infections due to aspiration while feeding. History of ear discharge, middle ear infections. Assessment of airway and plan of how to secure it. And any syndromes, whether it is associated with, what are the syndromes where you can have a cleft lip or palate defect? One is peri-Robin syndrome. Any other syndrome you know of?
Treacher-Collins.
Treacher-Collins syndrome, golden horse syndrome.
Apert syndrome.
Apert syndrome also, yes, you can have cleft palate, but not cleft lip commonly. And how is the weight gain and nutrition? What is the Kilner's rule of 10?
10 grams of hemoglobin.
Baby should
First
be at
start
least
from the age.
10
weeks
10
of age.
weeks.
10 weeks, not months, 2.5 months or 10 weeks of age. Then
10 pounds
10
weight.
grams of hemoglobin. Then
10 pounds weight.
10 pounds weight, not kilograms. Then
Counts should be less than 10,000.
10,000. These are the 4 tens that you have to remember. Age of the child to be 10, minimum 10 weeks, 2.5 months. Hemoglobin should be minimum 10 grams. And weight of the child should be 10 pounds, which is equal to almost about 4.5 kilos. And the WBC count should be less than 10,000 to indicate that there is no bacterial or active infection in the child because of the LRA or. Now, what is the embryology of cleft formation? This is a very common question they will ask you. How is this cleft happening? What is the time at which the development of the lip and palate happen in the baby? The
Usually
age
starts from the 4th week and goes to the 10th week of gestation.
completes at 12th week. Okay, and then what are all the components or the tissues that make up the lip and palate?
There is a frontonasal process, 2 maxillary and 2 mandibular process.
Very good. So totally 5.
5 process. Cleft lip formation occurs if there is a defective fusion of the frontonasal process with the maxillary process. Cleft palate defect occurs if there is a defect in the fusion of the primary and the secondary palatine shelves.
Good.
The palatine shelves develop from the maxillary and mandibular processes.
Also, very good. So development starts at 4th week of gestation, completed by 12th week. 5 facial prominences occur. One is called the frontonasal, then there will be 2 maxillary and 2 mandibular process. And failure of fusion of frontonasal with maxillary process results in the cleft formation. How do you manage anesthesia for these cases?
So, IV induction and general anesthesia with flexometallic or RAE South Pole tubes.
So that's all the answer for that. What about the starvation guidelines? What about feeding? What about pre-medication? What about separation anxiety? All these things have to be, because this is a very commonly kept case, they may ask you all the details to see whether you have handled any cases of cleft lip or palate during your training. Okay. So I am giving the details in little more elaborately. Avoid sedative pre-medication, because most of the examiners will not like you to say, because this is an anticipated difficult airway. Most of them do not accept the answer that any sedative pre-medication is given. And because these children are, especially when they come for lip, it is hardly 3 months old baby, the separation anxiety also will not be there. So the feeding guidelines and NPO guidelines are more important in these cases. So what is the current feeding guidelines that you have to follow?
So we can give clear liquids 2 hours prior to.
What about the mother's milk and
4 hours for
It's
breast milk,
4
sir.
hours for mother's milk, 6 hours for cow's milk or formula feeds.
formula feeds? Very good. So that is the current guidelines which most of the examiners are very fond of asking. So follow current NPO guidelines and avoid dehydration. Prepare OT at a higher ambient temperature. Commonly, as I told you earlier, it will be 16 to 18 for adult patients. But for pediatric cases, it is better to have the temperature between 22 to 24 and use Burette IV sets for babies below 10 kg, so that you can give the correct fluid based on the, what is the formula that you use for IV fluid replacement?
Holiday Segar formula, 4 to 1
Holiday
rule.
Segar formula using 4 to
4 to
1.
1.
That number also you have to say. So 4 ml up to what weight?
First 10 kgs, 4 ml per kg per hour. For the next 10 kgs, 2 ml per kg per hour. And after that, for every kg, it's 1 ml per kg per
1
hour.
ml per hour. Very good. So they can ask you suddenly, supposing this baby is 4 kg, how much of fluid you can give? The child posted for cleft lip weighs 4 kg. How much fluid you will give?
40 ml maintenance fluids.
4 ml for first 4, up to first 10
Or
kg.
16 ml.
So you will give 10 babies only 4 kgs, ma.
16 ml.
16 ml.
Ah.
That is the maintenance. So we have to calculate for fasting and.
You have to take into account the fasting period also. Okay. So for every hour you can give 16 ml. That is the calculation. So the number of hours of fasting you have to take into consideration. For example, you are given clear fluids up to 2 hours. Then the next 2 hours of fasting you have to take. So 16 into plus 16 for 2 hours is 32. And the first hour will be 16. So up to 48 ml you can give during the first hour. Okay. That is how you must fill the burette so that you don't overload the child. Okay. And dilute and label all the drugs, because all the drugs are in milligrams. Sometimes we may have to administer drugs in micrograms. So dilute them as much as possible and give the correct dose of the drug. Then check the machine, Jackson-Rees breathing circuit, correct size face mask, gauze or operator. What is this operator?
So it is a device that is placed inside. If there's a white cleft palate, we have to place it there so that the laryngoscope blade doesn't get stuck into the cleft.
Very good. And it is made up of plastic. It is customized. Okay, it is mainly given to help the mother with the feeding of the child without aspiration. So it is made preoperatively. That is why I told the earlier stage what are the feeding difficulties and how they were managed. So majority of the children in the rural setup, they will use the palate and feed it through the side of the mouth, through the sulcus. Whereas in the urban area, they may get a plastic shelf-like thing to cover that palate defect and fix it like a oral denture and feed the child and remove it, wash it and keep it. So that operator can be used during induction so that the blade will not get caught in the cleft. Okay? And suction has to be checked and different sizes of laryngoscope blades. You must always have the difficult airway cart ready. The appropriate size plane and oral ray tube should be kept ready. And purposely I have missed one thing. What is the important thing that is missed in this, along with all these preparations?
Throat pack, sir.
Throat pack for palate surgery. Any human help?
Assistance and
You
experience.
must have either an experienced anesthetist with you or a good theatre assistant who can help you. Okay, that is a very, very important thing which I have not included purposely. So always make sure that you have good helping hand when you do a small baby with an anticipated difficult airway, especially the shared airway. Okay. Then plan for induction, GA, inhalation, or if IV access is not available, you go for inhalation induction. And if IV access has already been placed, then you can go for IV induction with the induction agents like propofol, ketamine, whatever you want to use, you can use. And assessing depth of anesthesia after inhalation induction. That is a question that they may ask you. So how do you know that the child has gone into the surgical plane of anesthesia? What are all the clinical signs that you look for? I think this I have been repeatedly teaching you in the classes on pediatric anesthesia. 3 important signs which occur clinically. What about the respiratory rate? What will happen? Supposing you bring in a conscious child and put the face mask onto the patient's face and start giving oxygen and sevoflurane.
So
What will be
initially
the
it will be
initial
tachypnea, but
Rapid shallow breathing, then after achieving the depth, the rate will decrease.
rate will come down, sir.
Yes, rapid shallow breathing will be replaced by deep slow breathing. Okay, so the rate will definitely come down. That is one of the important, very, very easy method of assessing the depth of anesthesia. Number 1. Number 2,
Relaxation of limbs.
relaxation of the limbs or abdominal wall. Usually children have a protuberant abdominal wall, if you see, because their abdomen and thorax are slightly more bigger. So they will have a protuberant abdomen that will cave in, that will become scaphoid. That is number 2. But the third important thing is the
Loss of
eyesight.
response.
Yes. Initially, if you watch the eyeball, it will be having a roving eyeball, moving right and left or rotating. So it is called the roving eyeball will be there during early stages of anesthesia. But once the surgical plane is achieved, it will come into the central position and it will not move. It is called the central fixed gaze of the eyeball. That is the most important sign. So respiratory rate decreasing and depth increasing, abdominal muscles becoming concave or boat-like, and 3, the eyeball getting fixed in the central position. These 3 are considered as the classical features of adequate depth of anesthesia as described by, who described this?
planes of anesthesia?
Goodles.
Sir Ernest Goodall. Okay, Goodall stages of anesthesia. So that also history will be asked suddenly. You must be ready to answer that. Okay, right then. Methods of securing IV access, use of emla cream. Questions may be asked on emla cream. What is emla cream?
Eutatic mixture of local anesthesia, prilocaine and lignocaine.
2.5%.
2.5% each. Okay. So how do you apply that and how do you?
It should be applied 45 minutes prior to
half an hour to 45 minutes prior to cannulation. We have to
dressing.
dressing.
You must have an occlusive dressing. Okay, you must put a transparent this IV dressing should be applied there, so that it is in good contact with the skin, and wait for 45 minutes to 1 hour to get the adequate analgesia before you cannulate the limb. And intubation using SAXA in anticipated difficulty airway, or you can go for retracurium or retracurium, whatever you are used to. The straightforward cases with oral grade tube. That is the most preferred tube, whether it is cleft lip or cleft palate surgery. And monitors to be used are SpO2, ECG, EPCO2, NIBP, temperature monitor, and precordial stethoscope. Where do you place the precordial stethoscope?
Over the apex beat.
Over the apex. So, is there any better location? Just below the suprasternal notch will be a better position, because you can monitor both the respiratory sounds as well as the heart sounds. So it is preferable to place it below the suprasternal notch on the left side. Okay. So take care of ET tube during positioning for surgery. So normally, even for cleft lip, they want a little bit of extension. By placing a tumble rule under the shoulders, they want the head to be little extended. And what is the nerve block that you can give for lip surgery?
Spino maxillary nerve.
Lip surgery, what is the block that you can give? Bilateral cleft lip or unilateral cleft lip, whatever the cleft is there. If the surgery is planned as a lip repair, what is the block that can be administered? Bilateral infraorbital nerve block that has to be given. Okay, nerve blocks for intraoperative pain relief before surgery. I have specifically not mentioned the name because you have to know that you have to give intraorbital nerve block. What is the landmark for that in a small infant like this?
Inferior orbital ridge.
Inferior orbital ridge. Give it there immediately. So close. Intraorbital foramen is below the inferior orbital ridge. It's lateral to the ala of the nose, 1 centimeter lateral to the ala of the nose. I think all these pictures are there in the class on cleft lip and the short case scenarios discussion. Earlier, I have given all those pictures there. So please go through them. And older children, if they have teeth, what is the mark? How do you assess the position of intraorbital nerve?
Medial to second molar, sir, in the hard palate.
Canine, just above the canine tooth. Okay, so that is where the intraorbital nerve emerges. Placement of throat pack only for palate surgery. So that is the time you have to take care of the tube also. And confirm bilateral air entry in 3 stages. 1 after intubation, 2nd after positioning, and 3rd after mouth gag placement in palate repair. So they may ask you, when all do you check the air entry? These are the 3 times that you have to check: after intubation, after positioning, after mouth gag. Observe blood loss during palate surgery. I have just combined some things about palate also, because if it is a palate discussion, then these are all the things they will ask you. The surgeons may infiltrate adrenal saline to reduce bleeding, and They may ask you about the correct dilution. How much of dilution you have to make if the surgeon wants to infiltrate adrenal saline for palate repair.
1 and 2 lakh.
How do you prepare that? You are right in saying 1 in 2 lakh. How much you add to how many ml of saline?
20 ml of
20 ml of saline and 1 ml of
yes.
adrenaline. Is it the way? How much is 1 ampule of adrenaline?
1 milligrams.
1
1 in
1
1000.
in
1
1000. It is 1000
1,000.
micrograms. It is called also 1 in 1000, isn't it?
1 in
Yes.
1000. First
1
dilution will
milligram.
be in 10 ml.
Pardon, ma?
0.1 ml, 0.1 mg in 20 ml.
1 mg is you require all very, very small, what do you call that, tuberculin syringes, all that to take 0.1 ml. What is the easier method with the available syringes and you can put 1 ml of adrenaline in 200 ml of saline. Okay,
Yes.
even though it is going to get wasted, it is easier to prepare like that. 1 ml of adrenaline, it is 1 in 1000. 1 ml is equal to 1 milligram, which is 1000 micrograms. So this is added to 200 ml of saline. So it is getting diluted 200 times. So it becomes 200,000. That is 2 lakhs, whatever number we want to say in like commercial, colloquial way. But it is 1 in 200,000, which means how many micrograms are there in 1 ml?
5 mics.
5 mics is there. Okay, so you can give up to what is the maximum dose you can use? The maximum dose is 5 mics per kg. Okay, so if it is a 4 kg child, you can ask the surgeon to infiltrate only 4 ml of this dilution. Okay, so 4 into 5, 20 mics will be the maximum safe limit. Beyond that, what will happen? Supposing surgeon is new and you also don't teach him correctly how to dilute, and he gives 10 ml of this diluted solution. So it will be 10 into 5, 50. That is almost 2.5 times of the baby's weight. So what can happen if wrongly they inject 10 ml instead of 4 ml?
Ischemia and necrosis of
Ischemia and
hemodynamic.
necrosis of what? What is the purpose of this infiltration?
To decrease blood loss.
To reduce bleeding. It is written here, adrenal saline to reduce bleeding. So only the mucous membrane injected there becomes, the vessels go into spasm, and that is the way to reduce the bleeding. But if you exceed the dose and give more than what is recommended, it will get absorbed systemically and produce all the systemic effects of the drug, like tachycardia and hypertension will happen. Okay, so very, very important, especially in small babies, to use the correct dilution and correct dosage. So 5 microgram per kg by producing a dilution of 1 ml in 200 ml of saline. That is the easiest way to remember, so that every ml will have 5 micrograms of adrenaline. And 1 ml per kg is the dose of that particular dilution. Okay, is it easy to remember?
Yes, sir.
Okay. And clear oral cavity after palate repair. Ensure removal of the pack also. And extubate in lateral position after full recovery and adequate reversal. This is the safe position always, whether it is lip or palate. I always do that in the lateral position, taking all the supports from the back, turn the baby to the right or left, and make sure that the child responds well to your oral suction by opening the mouth, and then adequate. Always any patient before you extubate, what is the important safe practice to do to see whether they will be they are having an adequate respiratory effort or not? How are you all trained to continue with the oxygen supplementation and extubate, or disconnect the oxygen supplementation?
Can disconnect.
Always
check
make
for-
sure that the saturation is maintained when the child is breathing room air at least for 2 minutes, or any patient for that matter. If you have intubated any patient, disconnect and completely allow the patient to breathe only room air for minimum 2 minutes, and make sure that there is no drop in saturation and they are able to maintain that. Then it is safe to extubate that patient. Okay, this is a good practice to follow so that you don't land up with a desaturation after giving 100% oxygen and continuing to extubate with the oxygen is not at all a good practice. Okay, so that you can find out if they have any inadequate breathing. When they breathe room air, naturally the saturation will start dropping down. So you know that their power is not adequate. You can wait for some more time or give some more reversal and then safely extubate them. So make sure that room air saturation is between 95 and 98, at least for 2 minutes before extubating any patient, whether it is a child or an adult. So, and observe for any bleeding or airway obstruction, especially in palate repair. So those are the questions that you can expect with regard to the flip. So this is a case of lumbar meningocele. Diagnosis given. What are the anesthetic challenges?
So pediatric patient, positioning difficulty will be there.
Position,
Infection
operative position,
risk might
wrong
be there
position.
if
So
it is
challenges
open.
in pediatric anesthesia, neonatal or infant based on the timing of the surgery. Anesthesia and prone position. Sometimes again here also neuro monitoring may be required. Possibility of blood loss, hypothermia and neurological damage. What degree of evaluation to be done?
So neuromuscular integrity. We have to check for
Neurological deficits, whether
neurological.
whether the child is moving the lower limb or not, because it's a lumbar meningocele. We do not know whether the child is born with paraplegia or not. So make sure that the motor and sensory in the lower limb is adequate. So, but again, go for birth history, term, preterm, normal vaginal delivery, Abgar score at birth and after 5 minutes. Any neonatal intervention was needed at the time. Motor and sensory evaluation of the limbs and documented. This is very, very important. And status of meningocele, possibility of rupture or infection, and need for early repair. Rule out hydrocephalus. Only children with the meningocele may also have hydrocephalic things and any other congenital anomalies. Then airway assessment and plan to position the baby for induction, because this is a lumbar meningocele. When you put the patient on the back, supine position, this may get compressed. So you must, how do you manage that?
So we can use a donut or we can try intubating in lateral position.
Lateral position, good, very good. So this is the alternate that you have. Discussion with the surgeon for use of intraoperative stimulation. Coming to anesthetic management. GA. Okay, first always tell the technique of choice. We have to definitely give GA. So follow NPO guidelines. No pre-medication needed, and most of them are infants. OT temperature to be raised to 32-24. Prepare for proper support of the baby without pressure on the meningocele like donut ring. Warming devices to prevent hypothermia. Inhalation or IV induction. Paralysis with neuromuscular blocking agents. Intubation with oral plain flexometallic tube. Maintenance with inhalation agents or TIVA depending upon neuro monitoring, just like as we discussed in the scoliosis. And standard monitorings like SpO2, EPCO2, EKG, NADP. If you think this is a very huge meningocele with the possibility of blood loss, you can go for IBP also, intra-arterial BP monitoring, temperature monitoring, urine output monitoring, and neuromuscular
monitoring also has to be done. This is different from neuro monitoring for the nerve intraoperatively. This is the neuro monitoring for the use of your relaxant if you are not going to do neuro monitoring. And analgesic, you can use fentanyl or LA blocks, like what we do for the regular spine procedures. And what are the post-op challenges?
So nursing should be
It has
done
to be
under
done in the prone position. Okay?
position.
Need to maintain prone position, adequate ventilation, and pain relief, monitoring of delayed neurological deficit. Okay, so sometimes neuropraxia or injury to the nerve can manifest as neurological deficit, which may not be immediately noticed, but it can happen later. Okay.
Acromegaly.
Acromegaly, very good. Adult patient with acromegaly. What surgery may be done in this patient?
Pituitary adenoma excision.
Excision, very good. Maybe pituitary excision or any, they can come for incidental surgery also. Supposing he has a hernia, he can come for hernia also. Okay.
Yes, sir. Yes, sir.
So, what are the challenges if he is posted for transsphenoidal excision of the pituitary tumor?
So difficult
difficult airway, very good. Then airway soiling can happen because it's transsphenoidal, means it's going through the nose.
Yes, sir.
So airway may be difficult to secure. Tumor may be functional with hyperactivity, especially you have to rule out hyperthyroidism. Tumor may be non-functional and be a macroadenoma, which may cause a raise in ICP. Okay? So these two are the important pathological things because of the adenoma. It may be an active tumor with all the hormonal changes, or it may be a non-functional, but size may be big to cause raise in ICP. Airway to be secured well and connections checked before draping, as it may be difficult to reach in case of disconnection. And because what is the position in which this patient, this transsphenoidal pituitary excision is done?
Right position. Head and elevation.
Elevation. Patient will be in 45 to 50 degree end up in elevation, not just like supine. Okay?
Yes, sir.
So this is semi-recumbent position.
Sir.
Pardon? The airway to be well checked and what investigations are needed for this case?
So routine investigations along with the hormonal tests, the thyroid function test, cortisol level.
So estimation of prolactin, insulin-like growth factor, plasma cortisol, urinary free cortisol, total and free thyroxine, thyroid stimulating hormone, late-phase hormone level. So if it is a functional adenoma, all the hormone levels have to be checked. Okay, so depending upon whether it is functional or non-functional, this is the test that you have to do. And basic metabolic panel like electrolyte and metabolic abnormalities and PBC have to be done. And the pituitary MRI scan to assess the position and extent of the tumor may be needed. Okay, that will be a clue about whether it is going to cause ICP or not. What challenges are there in monitoring this surgery?
So we have blood pressure, difficulty in monitoring the blood pressure because of acromegaly.
Pressure monitoring. By what means? NIBP, non-invasive or invasive?
Non-invasive blood pressure monitoring is difficult.
Why? You may have a huge limb, but you can use extra large and you can use it in the forearm. But main thing in the class I told you about IBP, radial artery cannulation. Why it has to be very careful in these areas? I thought we discussed this in class.
management of probably pituitary adenoma, transvenous surgery, we will discuss in one of the lectures. So, ulnar artery obstruction due to carpal tunnel syndrome, it's very common. So, if you are
Yes.
planning for IVT with an intra-arterial line, perform Allen test before radial artery cannulation. If not found safe, place the cannula in dorsal ischemic artery and precordial Doppler to avoid the risk of venous air embolism because the patient is going to be in the head up field. These are the two things very specific to this particular surgery, apart from the other routine monitoring. What are the intraoperative challenges?
So we don't have access to the airway and IV. So we need extensions for IV and
So
circuit.
large bore peripheral access as needed may be what is called twisting carotid anomaly, where the internal carotid arteries may be very close to the tumor. And if the surgeon accidentally makes an injury to them, you may have torrential bleeding. Then positioning is a semi-recumbent with head-up position with cervical extension, and this position to be done in a gradual fashion to avoid sudden hypotension. So if you straight away lift the patient from supine to 45-50 degree head up, they may have a sudden hypotension. So it has to be done in gradual elevation and backup airway equipment before intubation, even small size differential tube, because sometimes there may be a subglottic narrowing because of the external compression. And oral flexometallic tubes are the tubes of choice and fixed on the side opposite to the side of the surgery, because they may usually go through the right nostrils and try to pierce that and do the surgery. And all connections in the circuit to be checked prior to the start. A throat pack is inserted and you must have a clear label attached to that patient so that you remember to remove it at the end. Depending upon the need, sometimes they may, supposing in some dural injury occurs and there is a CSF leak, they may immediately on the primary stage itself put a fat graft or a facial attack graft. So these areas are also prepared and draped. And eyes should be padded and other pressure points properly supported. Unexpected hemodynamic changes can happen during two stages. One is surgeon may apply vasoconstrictors like xylometazoline or other ephedrine nasal packs, which may cause increase in blood pressure and heart rate, or stimulation during endonasal approach also. If the patient is not in correct plane of anesthesia, that may also cause a tachycardia and hypertension. And you have to put a pneumatic compression stockings and compression devices in the leg to prevent the risk of DVT. What is lumbar drain? How it is useful during this surgery? We discussed this in very recently. Pituitary adenoma surgery class was there in early thing last month or before that.
Sir, by draining the CSF, it will cause the tumor to drop down. Something like
Drop down, or if it drops down, it is. You drain the CSF, it will not drop down. You have to increase the pressure to make it drop down from the lab. Okay. Inserting a 16 gauge epidural catheter at L3 L4 space and setting it in the subarachnoid space for about 10 centimeters called lumbar drain. Okay. And what you do is it helps to push the tumor down when you inject 10 ml of sterile saline into the spinal CSF column. It will increase the pressure and push the adenoma downwards, because it will increase the intracranial pressure and push the tumor downwards, which will help the surgeon to easily excise it.
And this may also help to prevent CSF leakage by reducing the pressure after surgery. So in case there is a dural puncture and CSF leak through the nostrils, by reducing the spinal pressure, by draining the lumbar CSF, the intracranial pressure will drop and the CSF leak will also come down. Okay, so both ways it is helpful. During intraoperative period, you have to increase the pressure. During post-op, if there is a CSF leak, you have to decrease the pressure. So in that way, it is helpful. What are the post-op challenges in these cases?
Hemorrhage, sir.
Bleeding. Yes, very good.
Bleeding,
Emergence and
CSF
reduced
leak.
post-operative
leak.
nausea and vomiting is very important. That can be achieved by use of TUA rather than inhalation agents. And avoid post-operative ventilation by adequate spontaneous respiration. Don't give positive pressure ventilation during extubation in these cases. That will increase the pressure, and if there is a CSF leak, it will worsen that. And use of remifentanil and dexmedetomidine injections are quite useful in this particular case. And suctioning of stomach and hypopharynx should be performed by the surgical team prior to turning over to anesthesia team for airway management. And don't blindly insert the gastric tubes through the mouth, because it may go accidentally through the skull base. And what are the complications of this surgery? First is bleeding. Second is CSF leak. Third is they can go in for diabetes insipidus after the excision of pituitary adenoma, or they may develop SAADH, syndrome of inadequate antidiuretic hormone production, venous air embolism. These are the 5 complications that you have to know. Then next common case scenario, short case scenario is anesthesia for adenotonsillectomy. What are the challenges in this surgery?
So pediatric age group, shared airway
Mostly
procedure.
pediatric age group, very good. Shared airway, very good. Then airway challenges, will be difficult airway sometimes.
Yes, sir.
Difficult airway.
Difficult
Difficult
area.
airway.
Patient
They'll
might have
be
an active URI.
reactive airway.
Right, OSA is also very common. So adequate patient preparation, pre-medication is important. Providing good surgical access while sharing the airway. Prepare free of anxiety of patients and parents. Preventing post-op nausea and vomiting, providing adequate analgesia. Preoperative airway management. These are the challenges. And prevention and timely management of post-op hemorrhage and other complications. What are the special concerns in tonsillectomy and adenoidectomy surgery?
So post-op hemorrhage, sir.
Airway edema and injury, airway obstruction.
Supposing, I will put it a little more understandable. Supposing they apply only for tonsillectomy and no adenoidectomy, or if it is going to be combined with tonsillectomy and adenoidectomy, is there any difference?
Sir, intubation, route of tracheal intubation.
But
If it is
adenoid,
combined, then oral intubation. If it is only
Concerns are those associated with the age, first of all, pediatric age group. Then the American Society of Anesthesiology physical status, recurrent URI and ear infections, and associated comorbidities like OSA and obesity and coexisting syndromes. History of bleeding tendencies, sometimes, that also can be a problem in these cases. And what investigations and pre-op preparations are needed Rule out ongoing LRI, OSA due to adenoids, TBC, coagulation profile. And discuss with the surgeon about the route of intubation, whether oral or nasal, depending on whether both TMA or only tonsillectomy. If it is tonsillectomy, you can go for nasal route intubation. If it is also adenoidectomy, it is preferable to go for oral intubation. What is the anesthetic management?
General anesthesia with endotracheal
Endotracheal tube
Free of-
intubation. Very good. So meticulous pre-anesthetic evaluation, patient preparation is key. Proper preparation of the operating room, including emergency drugs, airway equipment, LMA, RA tube, conventional ET tube, oral airways, and a good working suction, and good intravenous access. The IV full transfer, body weight to be calculated. Basic monitors, ECG, NABP, pulse oximetry, etc. Why ETCO2 is important? Very important in this case.
So it helps in identifying the tube disconnection.
Excellent.
Hypoventilation.
ETCO is important to detect ET tube obstruction. That is, especially when you put a nasal tube, sometimes you may endure and carry some of the tissues of adenoid or the terminate, and the tube may get obstructed. The tube might go into the larynx correctly, but ventilating the bag may be very difficult. So in that time, the or when the surgeon puts the gag and presses the tube and obstructs or displaces the ET tube, ETCO2 is the main thing which will tell you that such a calamity has happened. Which is the preferred induction agent for these cases and why?
So propofol is the preferred induction agent because it obtains the airway reflex.
Airway reflexes very well, very good. IV induction agent preferred because of its smooth induction and also suppresses airway reflexes better than your other agents. And intubation plan as per oral or nasal tube with SATSA in case of difficult airway. Otherwise, you can go for non-defaultive method. Maintenance with inhalation agents like CO or dexchlorine. You can go for spontaneous if your surgeon is very fast. Now, the surgeon with whom I used to work during my early days of practice used to finish both side tonsillectomy in 10 minutes. So, I have never controlled the ventilation, having done about 800 cases with him. So, by the time the patient comes out of SATSA effect, he will finish the surgery. So, in such cases, spontaneous can be allowed. Otherwise, you have to go for controlled ventilation. Of analgesia, short-acting fentanyl, non-opioids like para and SAD, and local infiltration. How do you do the local infiltration? What nerves are to be blocked? Only this sort of questions if they come, that is the one which you feel
Greater
bored.
and
The palatine block.
Palatine, say palatopharyngeal, palatoglossal. These are the two nerves. Okay, so remember that. The triple drug antiemetic, ondansetron, dexamethasone, metoclopramide is very important for preventing post-op nausea and vomiting. What are the post-op complications?
Sir, laryngospasm, airway
And
edema,
intermediate late, like that you can
Immediate
classify.
intermittent late.
Obstruction because of foreign body, laryngospasm, bronchospasm, desaturation. Post-op, you can have bleeding. How do you classify the bleeding?
so primary, secondary, and
Primary,
reactionary.
secondary,
Reactionary.
Right. So pain, throat discomfort, restlessness, nausea, vomiting, bleeding, laryngospasm, and even acute pulmonary edema sometimes can happen when the laryngospasm or the airway becomes narrowed. Strained breathing through that produces what is called negative pressure pulmonary edema. NEEP. Okay. So what is Corona's clot?
Sir, it is the
In the position
clot
with
occurs after adenoidectomy
Hmm.
in the choana. which
Posterior
leads to
open.
upper airway obstructions
In the
and
olden
then
days,
sudden cardiac arrest.
patients, post-op patients who after adenotonsillectomy, when they die, they found there is a huge blood clot which obstructed the airway and caused the death. So it was found out in the postmortem. That is called the coroner. Postmortem report is also called coroner's report. Okay? So coroner was the one who found out there was a clot. So it is called coroner clot, and it is nothing but a clot formed by the bleeding from the adenoid area. So how is post-observatory bleeding classified? Because we have said primary, secondary, and tertiary. The name of the mouth gag used in this surgery and what is its importance to anesthetist?
Boyle-Davis mouth gag.
Boyle-Davis mouth gag. What is important? Who are they? Boyle and Davis. Two people or same person?
Two people.
What are their names and what profession or what branch they belong to? Davis also was an anesthesiologist, but he was from USA. And Boyle is nothing but your Boyle machine inventor, Henry Edmund Gaskin Boyle. Okay, so this
Yes, sir.
Boyle got the actually Griffith Davis was the person who first designed the mouth gag with the tongue blade, and Boyle brought that to England and they modified it. And they included his name also. So it is called Boyle-Davis mouth gag. So that the Boyle is the same person who invented or introduced the anesthesia machine. Henry Edmund Davis Boyle, Gaskin Boyle. Okay? So anesthetic management. So anesthesia for strabismus or squint is another common question they will keep you. What are the types of strabismus you know of?
Convergent squint and divergent.
Divergent squint. Only two, unilateral and bilateral.
Unilateral and bilateral.
So binocular or uniocular. What are the important pre-anesthetic evaluation to be made?
So to rule out other congenital anomalies.
Okay. More than that, two important conditions we have to ask for in all squint patients.
Vision status, sir.
Visual acuity.
Visual acuity is ophthalmologist will take, not yours. What are you going to do by asking for visual acuity? Is it going to see the Snellen's chart during anesthesia? Two important things, isolated or secondary to muscular disorder. It's a very, very important thing. Okay? Duchenne's muscular dystrophy is commonly associated with that. Okay? So patient may have muscular weakness or it may be associated with the history of malignant hyperthermia. Okay? So which muscular disorder is risk of malignant hyperthermia and CNS conditions? So the answer for this is Duchenne's. Sorry, this is written as malignant hyperthermia is also another complication that can happen in strabismus surgery. So what CNS conditions can be associated with strabismus? Any neurological conditions? Cerebral palsy, myelomeniosine, hydrocephalus, craniofacial syndrome, neurofibromatosis, or seizure disorders. So ask for history of seizure disorders also in these cases. What serious conditions can be associated with strabismus? Two congenital problems. One is
BS. Congenital.
cardiomyopathy and congestive heart diseases like ASD, VSD, etc. Okay. What two important reflexes are associated with strabismus surgery? What is the pathway of these surgeries?
Sir, oculocardiac and oculoemetic.
Emetic, very good. Oculocardiac reflex, stimulation from extraocular muscle. So you must emetic. So you must always say the afferent pathway, the center, and the efferent pathway. That is the reflex arc. So stimulation from extraocular muscles leads to pulses. Front pathway is short and long ciliary nerves, which go through the ophthalmic branch of fifth cranial nerve to main sensory ganglia. These get connected to the motor nucleus of the vagus, and that vagus stimulation causes bradycardia. So that is the oculocardiac reflex. The oculoemetic reflex is again stimulation of extraocular muscles. Apparent pathway is through the three motor nerves, third, fourth, and sixth cranial nerves, which go to the vestibular nuclei, which again goes to medial longitudinal fasciculus of reticular formation, and this stimulates the vomiting center, which is close by, and that results in nausea and vomiting. So for the oculocardiac reflex, it is the trigeminal and vagus. For oculoemetic, it is 3, 4, 6 cranial nerves and vomiting center stimulation. There is different pathway, there is no nerve. It is direct stimulation of vomiting center. This is how you have to remember. Anesthetic management.
Pre-op evaluation, pre-medication, general anesthesia with endotracheal intubation plus peribulbar or retrobulbar blocks.
Blocks, very good. So adult surgery can be managed with peribulbar and retrobulbar block only, with or without sedation. Whereas pediatric surgery done with GA, either with TT tube or LMA, spontaneous and controlled ventilation. Atropine to be kept ready for managed oculocardiac reflex. Antiemetic prophylaxis should be done with the three drugs, which we said earlier: ondansetron, dexamethasone, and metoclopramide. And there is no contraindication, like congenital cataract, where we said ketamine is not to be used. Here we can use it because it's only a extraocular procedure and there is no risk of ICP. So if the examiner asks you, the child is a 3-year-old child and there's a lot of separation anxiety, can you give administer ketamine to frighten the child and bring it inside the KP? You can definitely say yes, you can give. There is no contraindication. Okay?
Yes, sir.
So, if you pick up the oral rate tube, what is post-duction test? Is performed during that Strabismus surgery.
So it is a test to identify the direction of squint. We have to cover one eye and we have to ask the patient to look straight. Then we have to uncover the eye which is covered and we have to look for.
Is it done pre-operatively? Means?
Intraoperatively, the surgeon will ask, sir.
This is done during surgery. Post-duction test is done by the surgeon.
Intraoperatively, we have to stop the muscle relaxants, sir.
So it is a test done by surgeon. Please remember. Please read this. It is a test done by surgeon operatively during surgery to distinguish any restriction in movement due to mechanical causes or increased muscle tone. Okay? So that's the main test. So how it is done is we will try to pull the muscle. The effect of muscle relaxation should not be there. The muscle should have the normal tone. So you should plan in such a way that you don't have the effect of any muscle relaxant. So it can be, so if the surgeon says I want to do the post-duction test, it's better to use extra for intubation and maintain spontaneous ventilation with normal muscle tone so that you can do this test comfortably. Otherwise, you must use a short-acting muscle relaxant like atracurium and make sure that the effect of the muscle relaxant is worn off. The patient has resumed spontaneous respiration during the performance of this test so that you can identify the muscle and correctly resect it and reattach it. Okay? So how can anesthetics help in doing anesthetics help in during this test? So we can use neuromuscular blocking drugs to produce complete muscle relaxation. This will paralyze and relax the muscle with increased tone, but cannot relax the muscle restricted by mechanical cause or fibrosis. Oh, sorry, this has to be done by complete paralysis, not to resume, but during initial stages before resection, some surgeons may like to do the test. At the time, it can do what I told about hexametonium and then spontaneous respiration. What is Bell sign?
Upward rolling of eyeball.
Correct. Upward rolling. Sometimes the eyeballs may remain rolled up, which is known as Bell sign. So this is how the eyeball will roll up during surgery. So how do you correct this? How do you get out of this problem? Does it happen under deep plane of anesthesia or lighter plane of anesthesia? It happens because of lighter plane.
Lighter
So
planes.
adequate depth will be important to maintain neutral position of the eyeballs. As I told you during inhalation induction, the central fixed position will happen only during correct plane of anesthesia. So if the Bell sign is happening, that means EA is inadequate. This is achieved by inhalation agents in adequate concentration or propofol infusion. So this is the how it is being done, the surgery, how it is being done. So the muscle will be resected and then reattached to correct the defect. So the process is done. What is shown here?
Supracondylar fracture of humerus.
Condylar fracture of the humerus. Very good. The X-ray lateral view in the middle picture. What is this to represent? In this picture,
One
you
is
have the
Anterior and posterior displacement.
flexion and extension deformity. It's not called anterior and posterior. It is called the flexion and extension deformity. That is extension type, which is the broken portion has gone behind the main shaft. Here it is remaining anterior, front of that. So flexion deformity. How is the clinical appearance of the supracondylar fracture described? To look very obviously disfigured. What shape it assumes? Finally, orthopedic questions.
Gunstock deformed.
This is how it looks. Can you tell me now what is the shape? Which alphabet does it remember?
Yes.
Escaped.
Called S-shaped configuration of the upper limb. Okay, so starting from here, if you write, it looks like an S. Alphabet S, isn't it? So it's called S-shaped deformity. What are the potential complications of this fracture which warrant urgent intervention?
Neurovascular
The
injury.
neurovascular deficit.
Neurovascular deficit, very good. Ischemia of the limb due to vascular compression or development of compartment syndrome. What are the challenges in this case?
So it is commonly occurring in a pediatric age group, sir.
Very good, okay.
And the patient will have only one limb, so difficult IV access. Radial nerve injury can be there, sir.
Challenges to you as anesthesiologist. Radial nerve injury is a surgeon's headache.
Yes,
To
sir.
take care of that. You are not going to be, you are not doing anything to that. Okay. But
Yes.
mostly pediatric age group patients, correct? And it can be an immediate, supposing they come with no pulse in the radius and they have eaten something just before falling down. What can
Yes,
happen?
sir.
Full stomach.
Increased risk of aspiration.
Presence of full stomach if intervention is emergent. Okay. Usually what happens is children come home Mother feeds them with some pizza, burger, or something after they come back from school, and immediately they go to play ball, break their limb. They come with a full stomach. Okay? So that risk is always there, and if the pulse is not there, the orthopedic surgeon will be jumping. I want to do it immediately, otherwise the limb will become gangrenous. So you always face the dilemma of whether to go for anesthesia or not. So management of anesthesia, these cases are adults and older children who can cooperate can be managed with a upper lip block. Even if the child has eaten, no problem. You can just give a good block and manage the whole procedure, the block itself. But in non-emergent cases, we have to wait for gastric emptying. Okay, and what is the risk? Even if you wait for the 4 hours or 6 hours, and then when the patient is in pain, gastric emptying is delayed or fastened.
Delayed.
Delayed. So they may still have some amount of full stomach. So what are the preparations you can do to prevent vomiting and aspiration?
Rapid sequence induction if in case we're going for GA.
Preparation. Rapid sequence induction is management on the table.
Give metoclopramide.
You can give
Prokinetics.
drugs to improve the gastric motility and emptying. So metoclopramide can be done. Use of drug like metoclopramide. What is the other drug which can cause increase in gastric motility? But this is not routinely used, but it also has a
Erythromycin, sir.
erythromycin. Fantastic. Who said that? Good. So acid aspiration prophylaxis to be administered and planning for GA. What are the drugs to be used for acid aspiration prophylaxis?
H2 blockers or proton pump inhibitors.
Proton inhibitors and metoclopramide also. Okay. So, and close reduction and immobilization can be done by IV induction and maintenance with inhalation and within under mask and spontaneous ventilation. But if it is any fixation with the pins and this thing, you have to go for RSI and control check on the airway. What is TAO or Berger's disease? Sometimes, very rarely, just to tease you, they may keep these cases, which are of course quite not very common, but very rarely, if they have a case like this, we may keep this.
Thromboangiitis obliterans, peripheral vascular disease.
Small to medium sized arteries involved, sir.
Only artery?
And vein also.
Is an inflammatory occlusive vascular disease of small and medium sized arteries and veins. So it is the entire vasculature except the capillaries. Okay, so all of them can be affected. Can affect also the cerebral, visceral, and coronary vessels. Okay, and heavy smoking is considered as a major cause for this particular disease. So these are all the things that happen. Active smoking leading to blood vessel damage, leading to hypertension. So lack of arterial blood flow to the, usually the tips or the digits, whether both in hands and foot can happen. So finger and toe discoloration, abnormal arterial growth is called corkscrew collaterals, ulceration and tissue loss, superficial thrombophlebitis. So you can have a thrombosed vein seen on the skin. These are all the features of this particular disease. What are the complications of this disease?
So, toe ischemia.
So it can cause severe gangrene, upper and lower limb digits, muscle wasting, ulceration, sensory and motor impairment, auto amputation, and sometimes embolism also can happen. So the surgical options.
Revascularization if there is collaterals are patent.
Why do you require revascularization if the collaterals are patent? They will be supplying the blood, isn't it? It is
So
not
because
a major vessel block. Because you can see in this picture, it is a small and medium vessel which are affected, not the major vessels like what you get in your regular atherosclerotic or a diabetic vascular disease, where the femoral or popliteal major vessels only can do a bypass grafting.
So if it is gangrenous, then amputation.
Yeah, sympathectomy, endarterectomy, amputation, and PTCA. These are the options that you can do for treating this condition. What is differential spinal for assessment of response to sympathectomy? So these cases will require either a palate ganglion dissection and blockade or a lumbar sympathetic blockade. So before planning to do that sympathetic excision, how do you find? How can you find out whether the sympathectomy is going to be useful or not? This is a common question they may ask you. Unfortunately, if this case is available in the, and you go for it. Yeah. So what is differential spinal? This is
So
a common thing all of you should know, having administered so many subarachnoid blocks.
it's the susceptibility of autonomic, sensory, and motor blockade.
The difference in the level of block. Okay, it's not
Difference.
the susceptibility. Normally,
Yes.
we check the height of the block. How do you check the height of the block? By checking what?
Sensory
Sensation. Either for pinprick or cold sensation. So we decide, for example, after giving a lumbar subarachnoid block at the L3, L4 space, you inject about 2 ml of 0.5% heavy bupivacaine. It doesn't stop at L3, L4, it travels upward,
Yes.
depending
Yes.
upon the position. And you keep on checking the sensory level. From L3, L4, it goes to L2, L1, L1, T12, T10, like that it goes and fixes up at T4 level or T6 level, let us say.
Yes,
So
sir.
T6 is the sensory level of blockade. So what will be the level of blockade for motor and what will be the level of blockade for the autonomic?
Motor is 2 level below the sensory. Sir.
Sensory and
Autonomic will be 2 to 6 segments above the sensory. Sir.
2 levels, mostly 2 levels. So this is called the differential spinal blockade. Okay. So if you use a very dilute concentration of local anesthetic, which will selectively block only the autonomic, can you find out whether the patient will benefit by sympathectomy? What is the clinical improvement that you will see? Because one of the concepts is there is a intense vasoconstriction. That is why you do the sympathectomy for these cases.
Vasodilatation and pain relief.
And temperature increase will be there. When there is vasoconstriction in the peripheral part of the limbs, the temperature, the skin will become cold because of the lack of blood supply. The warmth will not be there. So if there is an increase in temperature of 1 degree before the block and after the block, then you can say patient will definitely benefit from doing this sympathectomy. Okay. So this differential spinal is derived from the concept of different levels in block when hyperbaric local anesthetic agents are administered. After the maximum level of sensory block is achieved, motor block will be 2 segments below and autonomic block 2 segments above. Okay? So by using a very low concentration of LA agent, autonomic system alone can be selectively blocked, which reflects as improvement in skin temperature after the block compared to the pre-block state. So if there is an increase of more than 1 degree centigrade of the skin before and after the block, the patient will definitely benefit by sympathectomy. What is the anesthetic management you can think of? The choices of anesthesia, because they are all in the peripheral portions. You are just planning for a sympathectomy or an endarterectomy only. Commonly, only two things, regional or GA. So you can both RA and GA can be the technique of processing coronary perfusion, because I said here the coronaries also can be involved. So after assessing the coronary perfusion, asking the patient to go for cessation of smoking, you can think of giving a central urachal blockade or a stellate ganglion block with interstellate block or any repair of the digits, or you can go for GA with a EP tube or LM, whatever you want to do. This is the conditions shown here.
Burns contracture,
Burn
it
contracture.
means flexion magnified.
Post-burn contracture, yes. This is a child with a post-burn scar contracture. Very good. What are the challenges in this case?
So pediatric age group, difficult airway and
Difficult IV
venous
line.
access.
Difficult IV access. Okay. So challenges of pediatric patient with stranger anxiety and procedural fear also, because this child would have been treated with dressings and other things. So child may have a psychological fear of what the doctor is going to do. So they may not be very cooperative. They may cry at the very look of the doctor. So procedural fear and stranger anxiety both will be there, and anticipated difficult airway due to anatomical distortion of fixed deformity of the head and neck by the scar, and intraoperative difficulty in monitoring the blood loss and hypothermia. So how do you manage this case? These are the common challenges which you can think of. So how do you manage this case? What are the things you have to plan?
So TIVA with tumescence anesthesia or
Main
awake
problem
fiber.
is airway, isn't it? This
Awake
anticipated difficult airway. So how are you going to secure the airway? That is the most and foremost thing that you have to say.
So asleep fiber optic intubation.
So prerequisite to assess the difficulty in securing the airway, because it looks like a little grown-up child. Try to develop a rapport with the child, discuss with the parents the management plan, identify a location for IV access, plan for RA techniques for intra and post-op pain relief, and keeping difficult airway cart and front of neck access set ready. These are all the first preparations that you have to do. Second, decision about technique of securing the airway, whether to go for awake fiber optic under topical sedation or inhalation anesthesia, quick release of contracture under ketamine and LA, and then go for direct laryngoscopy and ventilation or use of LMA. These are the two options. FOB under topical, but this small child just putting the 2% xylocaine and trying to FOB may have not worked out well. So you can go for either IV sedation and then topicalize the airway and do the intubation with the fiber optic, or take up the child with inhalation agent, then topicalize the airway and proceed with intubation. Or the second option is you can give ketamine, small dose, subanesthetic doses, infiltrate the scar area here, and ask the surgeon to quickly release and extend the neck with the regular laryngoscopy and intubation. For that, you have must discuss with the surgeon, and both of you should have a good understanding and do this as quickly as possible to avoid any airway failure. And once airway is secured, it is routine maintenance with inhalation agent or PIVA and the multimodal analgesia. And other common question they may ask you is when to avoid SAPSA in post-burn contracture. What is the danger period?
24 hours to 2 years.
So maximum 1 year. Nowadays they say it has been reduced from 2 years to 1 year and even 6 months. Okay.
Yes, sir.
So what is the reason? Why you want to avoid SAPSA?
Pre-junctional receptors will be in the fetal form, so they'll be
more
Pre-junctional receptors.
during acute ones, there is high risk of hyperkalemia.
Hyperkalemia is the clinical risk which can result in ventricular arrhythmia, tachycardia, and defibrillation and arrest. But how is hyperkalemia produced? It is not the pre-junctional, it's called extra-junctional receptors.
Yes, sir.
Receptors which are on the surface of the muscles, apart from at the neuromuscular junction, they all proliferate. They increase in number. And they are more easily, they will allow the potassium to get released from the muscles by this sudden stimulation. So proliferation of the extra-junctional receptors causing release of potassium and hyperkalemia is the reason for avoiding sepsamectomy. Maintaining position after the surgery is very important for maintaining the graft or whatever repair you have done. And so immobilization will be done. For that, you must give good pain relief, otherwise child will be restless. And psychological and nutritional support also be taken care of. So what is shown here?
Non-healing ulcer, right foot.
Yeah, maybe ulcer in the right foot. Cause it's the case of ulcer in the ball of the big toe. The location is exactly, if you want to describe, it is called the ball of the big toe. How to manage if it is a non-healing ulcer due to diabetic Raisa? If it is a real patient, you can ask the patient whether are you a diabetic, how long you are a diabetic, what medicines you are taking, how you got this ulcer, all that history can be taken. But in a short case scenario, if they have to say whether it is a diabetic patient or not. So here they give you the history that it is a non-healing ulcer in a patient with diabetes mellitus. So how do you manage this?
Sir, glycemic control and debridement and.
So it can be managed with debridement of nephrotic tissue, allowed to heal spontaneously if it is superficial. Okay? So how do you know whether it is superficial or not? Which grading system will help you?
Would
Called Wagner grades.
Wagner.
Affected if deeper tissues, it has to be graded using called Wagner grades and treat accordingly. Okay? What are the important history to be elicited?
Neuropathy, sir.
History of diabetes duration.
Inquire about pain and sensation in the foot on the ulcer side, number one. Any altered bowel habit with constipation or diarrhea, because it's already said it is due to diabetes. So all the questions about what is the most important complication of diabetes?
Autonomic neuropathy.
Autonomic neuropathy, fantastic. So all the questions leading to find out whether the patient has autonomic neuropathy has to be asked. So altered bowel habit, any symptoms of GERD, erectile dysfunction if it is a male patient, giddiness on getting up from bed, to rule out orthostatic hypotension, effort tolerance, the ability to walk distance, climbing flight of stairs, any associated hypothyroidism, difficulty in extension of neck. If present, look for prayer sign or palm print sign. All these things are all questions to find out the severity of diabetes. Okay? Any native treatment or previous surgical treatment and what anesthesia was given for that procedure. So these are all the history of drowsiness or excessive urination or thirst with fruity odor in the breath to rule out what complication. This last question.
DK.
DKA, diabetic ketoacidosis. Okay? All those questions have to be used. How to describe the ulcer?
So discontinuity in the epithelium.
No. Whenever you describe the ulcer in the surgical side presentation, what are all the things you say about the ulcer?
Size, height, extension,
shape, margins, bed of ulcer, odor from the ulcer, pain and temperature of the skin. Okay? So these are all the things that you have to declare. And for additional, you have to do what is called monofilament test for sensation. And the ankle jerk, ECG, motor, dorsal STDs and posterior tibial artery pulsations to be checked. And ankle brachial index to be checked. What is ankle brachial index? What is the importance of that?
Rule out peripheral vascular disease.
Vascular disease. How do you do that? What
We
is
have
that
to
value?
measure the blood pressure in the upper limb and lower limb, and we have to take a ratio. If it is more than
Ratio of what? Both
Systolic blood pressure in the
Systolic
lower
blood
limb
pressure
high.
alone.
So it should be equal to 1. It should be equal in both places. Okay. If it is
Yes,
less in lower limb and more in upper limb, that means the lower limb perfusion is lower. Okay? That is the importance of ankle brachial index. This is the Wagner classification, grade 0, 1, 2, 3. So grade 0 is no ulcer at all. Grade 1 superficial skin involving full thickness, but no underlying tissue is involved. Grade 2, like what we see here, is a deep ulcer penetrating down to the ligaments and muscles, but no bone involvement or abscess formation. Grade 3 is a deep ulcer with cellulitis and abscess formation. Then grade 4 is localized gangrene itself, and grade 5 is extensive gangrene involving most of the foot. You know the Wagner. So the treatment will vary. Here, this grade 1 will, if you just do the cleaning and debridement, it may heal by itself once you have controlled the sugars. Whereas here, you have to do a much more extensive debridement, and you have to put a graft or something to heal this. And here also, it may require a flap cover or something because more bones and tendons are involved. Here, you may have to completely amputate that. Here also, amputation will be indicated. Okay? So that is the importance of this Wagner classification. What are the investigations you have to do before you take up this patient?
so routine investigations along with HbA1c, fasting, and postprandial blood sugar. And peripheral.
Okay, routine CBC, HPCT, platelet, and electrolytes, glycemic control, changes, RR intervals, CXR for cardiac size and typical pulmonary tuberculosis is very common in chronic diabetic patients. Echo for LV function and regional wall washing abnormality. Doppler study of the lower limb vessels to see the blood flow. Wound swab for culture and sensitivity to decide on the antibiotics to be given. USG abdomen to rule out any medical renal disease, especially if they are chronic diabetic. They may also have diabetic nephropathy, so which can be detected by doing the USG abdomen. How do you optimize the patient before surgery?
So glycemic control with the help of
wound
insulin.
infection with suitable antibiotic. Okay, this is of course most of the time the surgeons do that, but we have to know what antibiotic is receiving. Then glycemic control by switching over to short-acting insulin, especially if the patient is on long-acting insulins, you have to switch over to short-acting insulins. And even if the patient is only on oral anti-diabetic agents, you can give short-acting insulins temporarily for controlling the infection. Stabilization of comorbid conditions, ketone estimation to see whether any occult decay is present, uric acid estimation and treatment if needed for that, estimation of GFR, step to assess the renal function, cardiac medication management. What are the advantages and disadvantages of regional and general anesthesia for this surgery?
Advantages of regional
advantages
is
are
pain relief. It can provide post-operative also due to long duration.
first advantage is less fluctuation on sugar levels because we are completely blocking the pain sensation. We can identify hypoglycemia because patient will remain conscious, and good intra and post-op analgesia can be provided by adding additives, avoiding airway manipulation and aspiration risk. Okay? These are the 4 advantages of breathing. Disadvantages: if you give SAB, there is a more chance of hypotension, and especially if the patient has severe autonomic dysfunction, hypotension will be quite severe and not responding to the conventional treatment. So patients with very obvious autonomic involvement, better to avoid regional. Limited duration, so that surgery, if it gets prolonged, patient may require for anesthesia. And epidural is contraindicated if there is a infection in the distal vein. Hypothermia and shivering is another disadvantage. What are the possible RA techniques in this case you can think of?
Sir, ankle
Ankle
block,
block.
completive sciatic.
You block it.
Ankle block with
So don't say ankle block as the first answer, because
indicated.
if there's an infection, they may not allow you to do that. So SAB, continuous combined spinal epidural. Of course, epidural is going to be just kept in place but not activated. Continuous epidural, of course, if the gangrene and the infection is very severe, better to avoid that. Nerve blocks, ankle block for dry gangrene without infection, and intravenous regional analgesia. Okay, these are the possible techniques that you can think of. Indications, advantages and disadvantages of DA.
Sir, more stress and more fluctuation in the sugar level and difficulty in identifying.
Indications are first and long duration surgery, like flap cover or microvascular surgery, presence of autonomic nervous system involvement, and the patient refusal of RA, and severe infection in the wound. All these things indicate that you have to go for DA rather than RA. Advantage: patient comfort, provides good operating condition. Disadvantages are difficult airway, especially found out by neck extension inability or inability to detect intraoperative hypoglycemia. These are important to so we have to keep monitoring the CBG often when we do it under GA to check for any hypoglycemia. What instruction to be given for elective procedure? The diabetic patient.
Fasting guidelines, sir.
Fasting guidelines. Always start with that. Angiolysis with the oral benzodiazepine. Anti-aspiration prophylaxis if you are planning for GA. Stop antiplatelets if they are taking it 5 days prior to surgery. Stop AC inhibitors. Check CBG before shifting to OT and inform the value. Instructions regarding insulin management. So, how to adjust the dose and how to change from which insulin to other insulin are all the important things that you know. What is shown here?
Patient with tracheostomy connected on your ventilator.
With the ventilator, see, this is the tracheostomy tube in the middle, and you have something here like a mask with a corrugated.
Tracheostomy mask.
This is the patient with tracheostomy receiving oxygen supplementation through a tracheostomy mask and TPs. Okay, this is a combination of tracheostomy mask. You can see this is being separately tied here, and this is the TPs which is delivering the oxygen. What are the indications for tracheostomy?
So it is
prolonged
divided into
ventilation.
elective and emergency.
It is classified into elective and emergent. So emergent tracheostomy indications.
Sir, facial injury, upper airway obstruction, difficult airway.
So acute upper airway obstruction due to any reason.
Yes.
Can be laryngeal trauma. Third is 3/4 fractures. They're all a part of facial injury. Okay. Elective tracheostomy. Reasons are
Patient head and neck surgeries,
for prolonged ventilation in the
prolonged
ICU,
ventilation.
tracheal toileting, neuromuscular diseases with the patient having poor muscle power, subglottic stenosis, tracheostomy prior to head and neck cancer surgery or TM joint ankylosis release. So these are all some of the things. Obstructive sleep apnea refractory to other treatments also sometimes require a permanent tracheostomy. What are the techniques of performing tracheostomy?
So surgical tracheostomy in percutaneous dilation
Percutaneous,
tracheostomy.
done by open surgical or percutaneous technique. What are the complications of
So
tracheostomy?
early and late complications.
So
Bleeding,
intraoperative, that can happen during the surgery, or bleeding, airway fire, pneumothorax or pneumomediastinum. Late complications are acute obstruction, tube dislodgement, pressure necrosis and erosion, stenosis, tracheoesophageal or tracheoinnominate fistula. What are the methods of assessing the correct placement of tracheostomy tube?
So by connecting onto the ventilator and checking for ETC O2 tracing, sir.
Ventilator, apnograph.
Apnograph.
Endoscopy allows first a detailed assessment. That is the first and foremost very objective evidence. Apnography and cuff pressure confirm the tube is in the trachea. How to take care of tracheostomy?
It's intermittent suction to clear the tube.
Sorry. Periodically clean the stoma, change the bandage, change the ties, clean the inner cannula, use a humidifier, hydrate the patient, check for signs of problems like obstruction or dislodgement. Okay. How often the inner cannula needs cleaning? If it is a two-lumen, outer and inner lumen cannula, how often you have to clean the inner lumen?
3 times a day.
3 times
for
a
the
day.
first.
Remove and inspect the inner cannula regularly. What is the 3 principles in management of a blocked tracheostomy? Patient suddenly desaturates, becomes restless.
It is based on the duration of tracheostomy.
Waveform capnography is a prominent role in the early stage of emergency management. Oxygenation of the patient is a priority. Trials of ventilation or potentially displaced tracheostomy to be avoided. Don't try to ventilate the patient if there is a big clot or incrustation blocking the tube. Suction is only attempted after removing the potentially blocked inner tube. Then only you should apply the suction, not try to push the blockage into the lower part of the lung. So suction should be avoided after removing the inner tube. Oxygen can be applied to the face as well as through the hole. Simple methods of oxygenate and ventilate via stoma are described. A blocked or displaced tracheostomy is removed as soon as this is established and not as a last resort. Don't wait too long to remove the tracheostomy tube, because once you remove the tracheostomy tube, some hole will be there. The patient will be able to breathe through that. So don't wait till the last minute. What is PDT? Who introduced it, and what is the equipment named after it?
Percutaneous dilation tracheostomy.
Tracheostomy. Who introduced it?
Ciaglia.
Ciaglia in 1985. And the equipment is Ciaglia Blue Rhino Kit. What is the condition shown here?
Baby with hydrocephalus.
Child with hydrocephalus. Very good. What is the definition of hydrocephalus?
So it is the enlargement of ventricles due to obstruction.
Abnormal accumulation of
CSF in the brain. Hydrocephalus is the abnormal buildup of CSF in the brain. Okay. How is CSF produced?
choroid
Choroid plexus.
From the lateral ventricles.
Ultrafiltration. Cerebrospinal fluid is an ultrafiltrate of plasma by the choroid plexus in the ventricles of the brain. Okay? How is hydrocephalus classified?
So congenital, acquired, communicating, and non-communicating.
Okay. So functional, clinical, age-wise, pathological, communicating, non-communicating. Okay. Functional hydrocephalus, clinical, age-wise, etc. What are the clinical signs and symptoms of hydrocephalus?
Sir, head is larger than the body, shiny scalp with dilated veins, sunken eyeball.
So it can be, patient can present with signs of irritability, poor feeding, headache, nausea, vomiting, diplopia, visual impairment, dementia, incontinence, and pain disturbance. And the signs may be accelerated head growth, faster. Mother may say talipes, bulging fontanelles, forced downward gaze, developmental delay, tropia, papilledema, posturing, bradycardia, apnea, all these things are very severe cases. How is the condition diagnosed clinically?
With the help of signs and symptoms.
By measuring the occipitofrontal circumference. What is the normal circumference in a small baby, newborn baby?
35
34 to
centimeters.
36 centimeters. Okay, if it is rapidly increasing, it should increase only by 1.5 centimeter per month. If it increases more than that, that means it is a faster enlarging head size. What is this eye sign here called?
Sunset signs.
Called the sunset sign. With the eye rolled downwards, its sclera visible below the upper eyelid. See the white sclera below the upper eyelid. Normally it will be covered in the upper eyelid. What is NPH? What is the other name for that? How is it managed?
Normal pressure hydrocephalus.
Hydrocephalus. Other name for that?
Senile hydro.
It's called Hakim's triad also. Okay, Hakim's
Yes.
triad. And the features are dementia, gait disturbance, and urinary incontinence. Treated by that also requires a shunting procedure. Divert the, even though pressure is normal, you have to divert the pressure. What are the surgical treatment options for hydrocephalus?
Sir,
Ventricular
temporarily we can do extraventricular drain as an emergency procedure.
Endoscopic
Then
ventriculostomies can be done.
Ventriculostomy and the
Shunting.
definitive like shunting.
ventriculostomy and shunts. Okay. What drug therapy is used to treat this? What is the basis of this?
Diuretics.
acetozolamide.
Diuretics.
Acetazolamide or diagnostic is a carbonic anhydrase inhibitor used to reduce the production of CSF at a dose of 25 mg PAD orally. Furosemide is added later. Okay. The concept over the what is the basis? Choroid plexus have ion pumps and enzymes similar to renal tubules, where this enzyme carbonic anhydrase acts. Okay. Hence, this drug is used for treating this condition also. What are the anesthetic challenges in this case?
The large head makes the airway a little difficult, so we have to place a wedge under the shoulder to support the head. Or we can bring the head outside the table to intubate the child.
The anesthesia, it is a juvenile hydrocephalus. Challenges of difficult airway because of large head preventing proper positioning for direct laryngoscopy. Challenges of raised intracranial pressure and consequences. Describe the pre-op evaluation and optimization.
So we have to rule out any neurological deficit in the baby. Look for dehydration.
Look for evidence of severe ICP like altered sensorium, vomiting, irritability, etc., which decides the urgency to release the raised pressure. Okay. History of seizure, vomiting, or neurological deficit, and whether the patient is already on any anticonvulsants. That also is a very important history. And look for any coexisting congenital heart disease or spina bifida, which is a important anatomical defect. Down syndrome may be associated in some of the cases. Physical examination with special emphasis on cardiac, respiratory, neurologic, and airway. And anemia, electrolyte imbalance, and infections to be treated prior to surgery. And maintenance of IV fluid should be commenced preoperatively if the patient is already having vomiting to prevent hypovolemia, and if there is vomiting. Young infants may also require dextrose because they can become hypoglycemic. And standard fasting guidelines are advised. Most of the time, this is done as an elective surgery, but very rarely it may come as a quasi-emergency with severe ICP raise. Anesthesia management.
Sir, adequate fasting. We should avoid pre-medication in these childs, which will lead to hypoventilation and also aspiration risk is there.
And position of the head should be.
This is a conventional controlled ventilation is the treatment. Keep DA cart ready. Body temperature again 22 to 24. Position in supine with head tilt and slight head up. Basic monitors applied. Place 2 folded blankets below the body of the child so that the head can be placed on the table. Secure IV line and give injection glycopyrrolate 0.1 mg followed by propofol and natriureum. Medial laryngoscope is useful in anticipated difficult airways. Intubated with appropriate size with the tube. The fluid of choice will be NS or oral and avoid hypotonic solutions. Fentanyl 1 to 2 mg per kg, paracetamol and diclofenac suppository are indicated. Surgeon can infiltrate the scalp and tunneling sites with LA with adrenaline to reduce blood loss and provide analgesia also. Anesthesia maintained with oxygen, air, fluorine, controlled ventilation, and intermittent doses of atropine. Antiemetic under citron can be given. Residual pluralization reversed with neostigmine 20 mg per kg and glycopyrrolate 20 mg per kg. Extubate after adequate ventilation is established and all replacements are fully recovered. What are the post-op management you have to do?
Sir, adequate analgesia, antiemetic, daily neurological examination, and we have to look for any malfunctioning of shunting and signs of raised ICPs.
Excellent. Acute questions like head up tilt to avoid airway occlusion. Good shunt monitoring. Rapid fluid shift and drainage of last volume CSF may happen in huge hydrocephalus. Maintain adequate cerebral perfusion. Maintenance of isovolemia, isoosmolarity, and isooncotic blood volume is mandatory. Okay. Patient is not done. So what is shown here in this picture is a patient ready for modified ECG. What is ECG?
Electroconvulsive therapy.
Treatment for severe depression and other psychiatric conditions not responding to drug therapy are used as an adjunct to pharmacological therapy. And part of it is not. So they involves passing an electric current across the skull to induce the grand mal seizure. What are the characteristics of the current used? It is an alternating current, not a DC current, with a pulsatile square wave form. Length of the current is 500 to 850 milliamperes delivered by electrodes placed on the specific sites on the head. And energy used is 30 to 45 joules for duration of 0.5 to 1.5 seconds. The physiological changes that take place during this are the grand mal seizure induced, which has a short latent phase, followed by 15 seconds of tonic phase, followed by 30 to 45 seconds of tonic phase of seizure. There is a post-ictal phase, which will cause increase in during the grand mal seizure. There will be increase in CBF, cerebral blood flow, ICP, IOP, and cerebral oxygen consumption. And the serious response to the stimulus should be initial bradycardia and hypotension, followed by tachycardia, hypertension, and arrhythmia. And the GIT, then will increase salivation, increase in intragastric pressure, nausea, and vomiting. So, what is the mechanism by which this ECT works is ECT causes chemical and cellular changes in the brain that relieve severe depression by improving neurotransmission. The pre-op assessment of patient in ECT, detailed history and examination. Patient may be elderly with lots of comorbidities. TVS especially rule out any ischemic heart disease and hypertension, because the previous changes which we have seen can precipitate an acute myocardial infarction. CNS can result in CVA, intracranial lesion, or raised ICT. Musculoskeletal can result in osteoporotic bones can fracture, tears can happen. GAT can produce GERD and hydrocephalus. It can increase the pressure and the glaucoma may occur. Psychological conditions, severe depression, like bipolar or mania may be there. And medications, patients may be already taking SSRIs, inhibitors, or lithium. The pre-drug history has to be elicited. And the history of previous ECT and number of times and how the patient tolerated that ECT is very important. And dentition should be thoroughly examined for caries or loose tooth. Any artificial dentures, crowns, all that be taken care of, because during clenching they can all break. And clear pre-op instructions for fasting, stopping anticonvulsants, removing inhibitors, right cyclic antidepressant, SSRIs, benzodiazepam, and lithium to be injected. The challenges of anesthesia for ECT is the NORA procedure. The mnemonic for NORA is soap me. Can anyone tell me what are the components of this soap me?
Suction.
Open.
Oxygen. Second is O is oxygen. A is
airway cord.
airway.
Aggregation.
Pharmacy.
Medications.
See, S is suction, O is oxygen, A is airway equipment, P is pharmacy, M is monitors, and E is emergency things, drugs, all these things, okay? And short duration procedure, this is ECT, it requires quick induction and recovery. Post-op nausea and vomiting can happen, so that has to be treated. There should be a designated recovery area with adequate monitoring is important. Okay. Describe the steps in ECT. For repeat patients, review is conducted to ensure no acute changes in health or medication. Full assessment is repeated if there is any change in physical status. Consent vital parameters, fasting status to be checked. And intravenous access and full monitoring is secured. Pre-oxygenation and anticholinergic administration is important. Anesthesia induced and muscle relaxant is administered when verbal communication is lost. And gentle assisted ventilation is commenced and the patient is observed for signs of fasciculation. That is, you give a small dose of dexamethasone to relax the muscle but not completely paralyzed. That is called subparalytic dose of dexamethasone. And you place a bright block. EEG electrodes are applied to the patient's head and the paddles are placed on the temporal regions. Anesthetists and other people should be away when the current is being applied. The patient is evaluated for tonic-clonic seizure activity. The bite block is removed when seizure activity has stopped. Airway support continues and the patient is transferred to the referred room once spontaneous ventilation is returned. A warm drink or light meal is offered to the patient when appropriate and they are fully conscious with all the reflexes intact. So what is shown here, this is the last case scenario.
Bed sores.
This is the ulcer in the sacral area. So you should not straight away say bed sore. Okay, it's an ulcer in the sacral region, probably due to pressure necrosis. This is what we are saying. What is the pathophysiology of pressure sore?
Because of increase in the pressure, there will be decrease in the blood supply to the skin.
Sustained pressure. Okay, sustained pressure applied to soft tissues over bony prominences, leading to compression of capillaries, causing impaired blood flow, tissue ischemia, and necrosis. Okay. What are the risk factors for pressure sore formation?
Prolonged immobilization.
Immobility or
neurological.
immobility, poor nutrition, decreased sensation, diabetes, or spinal cord injury. Anesthetic management of debridement and flap cover in a paraplegic. How many of you have given or seen a flap cover being done for a pressure sore by plastic surgeons? Any of you have seen or not seen at all?
They've done rotational flaps.
That's what I'm asking. Rotational flap only. You have seen me. So paraplegic patients may have total loss of sensation or altered sensation in the ulcer site. Okay. Some paraplegic patients may have episodes of what is called autonomic hyperreflexia. It is also called autonomic dysraphism. This is a potentially life-threatening condition where strong sensory stimulus below the level of spinal cord injury triggers a systemic response like rapid blood pressure increase, sweating, and headache. Okay? So patients who have no sensation or no autonomic dysreflexia need no anesthesia, but only reassurance or mild sedation. Okay? So if this is totally asensate, you can easily do this rotation flap without any anesthesia. But patients with autonomic dysreflexia, with a history of sudden rise in blood pressure, headache, sweating episodes, they require anesthesia to block this reflux, which can occur during surgery. So this can be achieved by spinal subarachnoid block. You may be wondering, already patient is paraplegic. Is it safe to give spinal? Yes, you can give a spinal subarachnoid block even in a paraplegic patient to block mainly the autonomic dysreflexia. And if the patient is apprehensive and not willing for spinal, you have to go for GA. And if you plan for GA, do a thorough airway assessment and ask whether patient was on tracheostomy, because this is usually happens in patients with spinal cord injuries or patients who are on prolonged ventilation, and they might have had a tracheostomy earlier. So that will make GA the intubation more challenging. And you have to have a good IV access, fluid preload, vasopressors to manage any hypotension during infection, and they may have GERD also. So RSI provide SAXA, because prolonged bedridden patients also are potential candidates to go in for hyperkalemia. And to prevent hypothermia or hypertensive episodes, manage with LTG infusion, pressure point care, and eye protection and remifentanil. Okay, so these are all the things that I have to show you. So that was the rapid fire discussion. Was it really rapid or slow?